today's academic event is a joint venture by the Sri Lanka College of Obstetricians and Gynecologists, SLCOG, and Sri Lanka College of Haematologists, SLCH. To start the proceedings, we would be lighting the traditional oil lamp. It's my pleasure to call upon Prof. Sanath Glanarol, President, SLCOG, Dr. Anoma Veeravardhana, President, Sri Lanka College of Haematologists, Dr. Yasinta Costa, Consultant Haematologist, Dr. Indika Buteju, Consultant Resident Physician, Senior Registrar, Dr. Jayanti Bhavantan, and Senior Registrar, Dr. Dindu Kalayaraj. Thank you. The item in the agenda is the welcome speech, which will be delivered by Professor Sanath Glanarol, President, Sri Lanka College of Obstetricians and Gynecologists.
Yeah, thank you very much for your kind invitation. As a president of the SLCOG, I welcome all of you to this very important symposium on hematological aspects in pregnancy. So mainly it is anemia. I warmly welcome President of the College of Hematology, my colleague Anoma, as well as other members of the college, and all the other participants, senior registrars, and the medical students, and all those who have joined with us from the Zoom. As you are aware, there are 300,000 pregnancies happening in Sri Lanka per year. That means there are more than 300,000 pregnant mothers in Sri Lanka. Out of that, 30 to 40% of them are anemic. Sad to say, but it is anemic. So anemia is a huge problem for us as an obstetrician. Mainly it is iron deficiency, as well as I think number 2 is thalassemia, known to all of us. So we want to have a teamwork. It is a teamwork with the College of Haematologists to curb this national problem. For that, we need awareness and the knowledge, and we have to change our attitudes towards this. So, keeping that in mind, we have organized this workshop, and there are a lot of people I can see join from the Zoom. So, I wish this hematology update will be very much important for your day-to-day management and change in attitudes of management of pregnant mothers in anemia. So I'm not going to talk too much, and I think it is time to talk academic things in this update. And I wish all the best for this hematological update. Thank you.
Thank you. Next will be Dr. Anoma Veeravardhana, President, Sri Lanka College of Haematologists, addressing the gathering.
uh, welcome you all for this joint symposium uh, on hematological disorders related to pregnancy. It is my pleasure to arrange this symposium with Sri Lanka College of Obstetrics and Gynecologists to discuss matters related to hematology and pregnancy. Unity in diversity for better patient care is our theme for this year. And this is one step for joining with the obstetricians and gynecologists to discuss the matters and to deliver best care for the patients. I am sure you can learn a lot on these topics today, and I would like to take this opportunity to thank all my colleagues worked very hard to make this event success, and for all the trainees and the resource persons going to participate this session. Thank you.
So the schedule of the events today, there will be 3 separate symposia. Before I get on to details of each symposium, let me introduce the resource persons here with us today. Professor Hemantha Dodampahala, consultant obstetrician and gynecologist. Professor Pradeep De Silva, consultant obstetrician and gynecologist. Dr. Madhura Jayawardena, consultant obstetrician and gynecologist. Dr. Prabodhana Ranavira, consultant obstetrician and gynecologist. Dr. Ramani Pallemulla, consultant anesthetist. Dr. Indika Boteju, consultant resident physician. Dr. Yasinta Costa, consultant hematologist. Dr. Dhammika Gunawardena, consultant hematologist. Dr. Chandima Kulatilaka, consultant hematologist. Dr. Anuma Veeravardena, consultant hematologist, and Dr. Sampath Vitana Vasam, consultant cardiologist. Let us begin with the first symposium, which is scheduled for 1 hour. The theme is anemia. First speaker will be Dr. Harshini Jayakodi, who will talk on the topic, Take Iron Seriously for a Healthy Pregnancy. Dr. Lochani Dasanayaka will take on from there to discuss about hemoglobinopathy in pregnancy. Last speaker for the first session would be Dr. Punsisi Nisanka. She will discuss about pregnancy and anemia of chronic disease. We today hope to cover a wide range of clinical topics which are very relevant to day-to-day clinical practice within the short time period of half a day. Each topic will have theory points as well as a discussion between the speaker and a resource person. So let me please remind all the speakers to stick to the time limit as much as possible without carrying over to the next speaker's time slot, so that we can run the proceedings smoothly. Over to you, Dr. Harshini Jayakodi.
Good morning, everybody. Welcome you all for the Anemia Symposium. And I am Dr. Harshini Jayakodi, Senior Registrar in Clinical Hematology. First of all, I would like to thank SLCOG and SLCH for giving me this opportunity. So within next 20 minutes or so, you will go through a case discussion on iron deficiency anemia in pregnancy, as that is the commonest cause of anemia in pregnancy. Anemia in pregnancy is defined with trimester-specific cutoffs of hemoglobin. That is, in the first trimester, hemoglobin less than 11 gram per deciliter, and second and third trimester, hemoglobin less than 10.5 gram per deciliter. Postpartum period, hemoglobin less than 10 grams per deciliter. Hemoglobin should be routinely measured in every pregnancy at the booking visit and at about 28 weeks of POA. So let's move with the clinical case. She is Mrs. B, 35 years old housewife, P3, C2 at POA of 13 weeks. Booking visit, full blood count, hemoglobin was 11.2 grams per deciliter. with normal white cell and platelet count. She was started on ferrous sulfate, 1 tablet daily, with vitamin C and folic acid. So my first question is to Dr. Jacinta Costa, consultant hematologist. Madam, is it necessary to start prophylactic oral iron in every pregnancy?
There are different views on whether to use prophylactic oral iron in every pregnancy. According to this UK guideline, they say that there is insufficient evidence to point out benefits when oral iron was used regularly in all pregnancies. But they have given a few indications like this, where the woman might become iron deficient, and to use iron only in these conditions. But WHO recommendations are entirely different. They have recommended routine daily antenatal oral iron supplementation, and the dose is to be based on the estimated prevalence of anemia in that population. If the prevalence is high, like if it is more than 40%, they have said to give 60 milligrams of elemental iron daily. And if the prevalence is less than 40, they have said to give 30 milligrams of elemental iron. In Sri Lanka, according to the 2005 statistics, it is about 29%, but actually I don't know how it is now. If you go by the 29%, it's about 30 milligrams per day. And it is to be started as soon as the GI effects of early pregnancy has decreased and with association with folic acid.
Yes. Thank you, madam. And with that, I'll move to symptoms and signs of iron deficiency anemia. The important fact in that context is, as body iron stores deplete early in the course of iron deficiency, symptoms of iron deficiency develop even before the development of anemia. One of the common symptoms would be fatigability, and there are many other symptoms as well. So moving with the case, at the next clinic visit, our Mrs. B complains of recent onset fatigability and hair loss. She had not been able to take oral iron supplements regularly due to dyspeptic symptoms and epigastric discomfort. So at this point, her hemoglobin is 9.8, hemoglobin was 9.8 grams per deciliter, and she was referred to hematology clinic. On clinical assessment, she is taking average Sri Lankan diet, non-vegetarian, and there is no history of bleeding manifestations. And her second child delivered 3 years back, where she breastfed for about 2 years, and there is no family history of thalassemia or other medical comorbidities. On examination, she had mild pallor and otherwise clinically well. So we did investigations, including the full blood count, which showed hemoglobin of 9.8 grams per deciliter with classic features of iron deficiency anemia, as low MCV, MCH, and MCHC. And here's her blood picture with hypochromic microcytic red cells and few target cells and pencil cells. So we did the serum ferritin level, which came as 5 micrograms per liter. So serum ferritin in pregnancy level less than 30 micrograms per liter is indicative of iron deficiency in the absence of inflammation. But routine screening of pregnant women with serum ferritin is not recommended currently. And if anemia be detected in a pregnant lady without any other obvious cause, a therapeutic trial of oral iron should be given without a delay. In that case, we expect a rise of hemoglobin 1 gram per deciliter in 2 weeks' time. That has a diagnostic as well as therapeutic value. So our Mrs. B had iron deficiency anemia in second trimester of her third pregnancy. So my next question is to Professor Pradeep De Silva, Professor in Obstetrics and Gynecology. Sir, what are the effects of iron deficiency on the pregnancy and the fetus?
Thank you very much for firing a very broad question at me. But apart from, say, the normal known part of pregnancy and anemia and the effect of anemia on pregnancy outcomes, delivery and things, I will tell few things pertaining to the fetus, which is not known by many people. The fetus gets all iron from mother, and fetus is usually spared from any iron deficiency fetus itself, unless the anemia is very severe or the fetus is in third trimester of pregnancy. So even in severe cases, the effect of the fetus is mainly in the third trimester. So if the anemia of iron deficiency etiology is going to affect the fetus, you will see the effects on the fetus coming up in normal clinical scenario in third trimester. They give a gamut of things that you can have with iron deficiency, starting from IUGR, reduced fetal movements, the IUD, and so on and so forth on the growth of the fetus, the biophysical profile and this and that. But in my practice, what I have seen is most common. Now, it is very difficult to identify IUGR per se, because the definition of IUGR is the patient is not growing up to its potential. So we don't know the potential. So as long as the estimated fetal weight falls within the 2 lines of the graph, the baby cannot be said that the fetus is having IUGR. So the most clinically important thing I have seen in iron deficiency anemia in pregnancy is fetal death. Right? It may happen very occasionally, but it happens. And you don't know the efficacy of the placenta, which is unique. The size of the placenta, the efficiency of the placenta in exchange of gases, the maternal and fetal blood cells, their Bow effect, double bow effect, that type of thing we don't know, cannot predict. So therefore, in subset of patients, the manifestation is third trimester fetal loss. And another thing that we forget about fetus is fetus gets iron from the mother. So normally it's spared. But fetal brain growth accelerates after 24th week. So that's well on to the third trimester. So when this brain is growing, blood-brain barrier is open, which normally closes 2 weeks after delivery. And the basal ganglia and things store and keep iron. So that is the motor functions of future baby. So unless you have got access to enough iron, the basal ganglia and whatever the things in the brain which needs iron may not be optimal. It's just logical argument only. I don't think anybody has proven it, because it must be happening in different levels where it's not obvious. I may not be the Usain Bolt, right? But that is the motor functions. So it may have an effect on theoretical effect on the motor function of the baby if the anemia is severe enough to affect, and it is iron deficiency. So that's the thing that I think in this type of forum that you have to take. Otherwise, I am training anemia and PPH and death. That's common. Thank you.
Thank you very much, sir. And with that important fact, we'll move to the management of iron deficiency anemia in pregnancy. And it should include dietary modification as well as iron replacement. So normal recommended daily intake of iron in pregnancy, especially in the latter half, is twice that of a non-pregnant woman. So we need to modify their diet to improve the content of heme iron in their food, as well as to avoid inhibitors of iron absorption, and also to include enhancers of iron absorption along with their diet. And iron replacement is mainly done with oral iron, which is an effective, cheap and safe. And ferrous salts are one of the preferred option with the expected response of hemoglobin more than 1 gram per deciliter rise in 2 weeks time. So there are a lot of ferrous salt preparations and combinations with varying amount of elemental iron content, and there is no strong evidence to suggest that one formulation is more efficacious than the other. And we need to advise them to avoid food along with taking oral iron, and that is the empty stomach is preferred with oral iron treatment, and to avoid other medications, multivitamins and calcium supplements, antacids, to be taken at the same time. We should avoid, advise them to avoid those. And about a third of women may develop dose-related GI adverse effects. We also need to inform them. And iron polypeptide and polysaccharide complexes will have more tolerability, but may be expensive. So the third question is to Madam Dr. Jacinta Costa, a consultant hematologist. Madam, is it possible to minimize these GI adverse effects using modified release preparations?
Okay. We know that iron is absorbed predominantly in the duodenum and in the proximal jejunum. Modified release preparations are enterocoated drugs which have sustained release, iron release in the latter part of the small intestine. So therefore, since this part of the small intestine is not geared to absorb iron, this limits, when you use modified release preparations, the iron absorption is minimal. Therefore, for iron prophylaxis, iron deficiency prophylaxis, or even in treatment, modified release preparations should not be used.
Thank you, Madam. And there's another question, Madam. What is the best dosing regime of oral iron in the treatment of iron deficiency?
To explain that, I need to say a few words on hepcidin. Hepcidin is a negative regulator of iron absorption. It impairs intestinal iron absorption. When the hepcidin level is lowest in the morning, that is why we say to give the iron as the early morning dose. Oral iron supplements, once taken, will induce the hepcidin and the hepcidin will rise. And this rise persists for 24 hours. So, when it's there for 24 hours, when you give another dose on the same day, the second dose absorption is quite less. So therefore, iron absorption is maximized by taking once per day or alternate day oral iron rather than taking iron twice a day. So the optimum elemental iron dose is about 40 to 80 milligrams every day in the morning, preferably empty stomach.
Right, thank you, Madam. And once when we started oral normal range, we need to continue oral iron therapy for 3 months and until at least 6 weeks postpartum to replenish the body iron stores. So moving back to Mrs. B, she had intolerance to daily and EOD doses of ferrous sulfate due to the GI adverse effects. So what would be the next option? So then we have to consider parenteral iron in the form of IV iron. And it is considered from the second trimester onwards in women with confirmed iron deficiency anemia and who are intolerant or do not respond to oral iron. And also, if the woman is in her third trimester after 34 weeks of gestation with confirmed iron deficiency and with the hemoglobin less than 10, then the parenteral iron is indicated to treat iron deficiency anemia. There are various formulations and preparations. We are familiar with this iron sucrose, which need multiple infusions to replace the whole body iron stores. That is because the maximum dose per day is 200 milligram per injection. And there are these newer preparations like ferric carboxymaltose, ferric decimmaltose, which replace the total body iron with a single injection. And when we want to give parenteral or the IV iron, we need to calculate the dose appropriately based on the woman pre-pregnancy body weight, and also have to consider cost administration facilities. And for newer preparations especially, they can develop hyperphosphatemia during treatment. So moving back to clinical case, Mrs. B was given IV iron in the form of iron sucrose with a maximum dose of 200 milligram per day for 4 doses. And fantastically, she showed a stable hemoglobin of 12.5 gram per deciliter at 4 weeks, along with a normal ferritin level until labor, without any adverse fetal outcomes. So there are no special restrictions in women with iron deficiency anemia in delivery, but we need to practice for active management of third stage of labor. And few facts about the Jehovah Witness with severe anemia in iron deficiency. So we need to identify these women in pregnancy at the booking visit early, and clearly document what are the products and preparations that they accept and refuse. So hemoglobin to check anemia early in the booking visit as well as 28 weeks, and about 34 to 36 weeks is recommended. And time to time, we need to gather as multidisciplinary team approach and develop a care plan appropriately. Treatment with any nutritional deficiencies, including iron, folate, and B12, is necessary. And iron infusions and recombinant erythropoietin therapy may be considered for a woman not responding within an appropriate time frame to hematinic supplementation. And we need to plan her delivery in a tertiary care center with prompt management of hemorrhage as well as with the active management of third stage of labor. So with that, we came to a conclusion of anemia in conclusion of the case discussion of anemia, iron deficiency anemia in pregnancy.
Small thing to add, because we manage the patient up to delivery, the patient will go home and have a long period of lactation, because everybody is encouraging lactation in Sri Lankan settings. So the College of Obstetrician and Gynecologists view the requirement for iron supplementation, if you are supplementing, is the same as the latter part of pregnancy, and to continue the whatever the iron supplementation throughout the lactation period. Another small thing to add about iron deficiency anemia itself, don't think iron deficiency anemia can be treated only with iron. You think the all mechanism of assimilation, collection and production of red cells will be returned back to normal when the anemia is the iron is given. It doesn't happen. Say, take for example of a car. You keep the car without petrol for a long time. You think putting petrol and then igniting it will start the car. No, it doesn't happen. So the clinical picture and your diagnosis may be iron deficiency, but supplementing iron itself in pregnancy will not give you the expected rise in all. So in such cases, the use of erythropoietin, as she said, is good. We have seen positive results of iron deficiency is better. Likewise, to emphasize what they have said, iron deficiency, oral iron, it doesn't get absorbed in everybody, right? So even it is iron deficiency, sometimes, as the speaker said, the IV iron needs to be considered. Don't keep on giving iron, and you will lose the track of patient, because today she will come and see you, next day she will come and see somebody else. In Sri Lankan context, if you think the patient is going to be anemic, better to be followed up as intermittent inward patient. So the patient in pregnancy is having that care plan better monitored. Thank you.
I would like to ask our physician about use of erythropoietin in pregnancy.
Use of erythropoietin in pregnancy in UK guidelines, Australia and there's no place as such by them, but there had been a few studies done with regard to this with erythropoietin in pregnancy. What they have found is Now, if we give IV iron to a pregnant mother, we can achieve, the replacement of iron storage early than giving oral iron. But however, with erythropoietin, they have found the recovery of or the optimization of the hemoglobin is faster than giving IV iron only. So there's a place, but it is not in the guidelines. So at the moment that we are happy to see that we have practiced that in Ragama, but the thing is we have to show with the data and the evidence, which is two things. We have to show that there's no harm by giving erythropoietin, and then there's some clinical and clinical outcome, good clinical outcome by doing so, because it's we have to consider the cost factor also. So those things, I think, if we have data, I better we do. And one other thing about the hemoglobin anemia effects of pregnancy. So most of the patients, some of the patients refer to our clinic in pregnancy with lethargy and shortness of breath and tachycardia. We found them to have hemoglobin of 9.5, sometimes 9.8, right? And when we go through them and when we try to find the cause, there's nothing significant, but only the anemia. So around 28 weeks to 32 weeks, their cardiac output is getting increased, and there will be a small, there's a tachycardia also, maybe around 90 to 100. And actually, a small drop of hemoglobin matters them. So that's the reason. So in that point, from pregnancy point of view, for the woman, it's very important to maintain hemoglobin more than 10 if the patient is having those kind of symptoms.
Okay, thank you very much. Hemoglobin disorders in pregnancy. Moving partner counseling, we did the partner screening. He did not have evidence of thalassemia or hemoglobinopathy. We arranged family screening and we continued folic acid supplements and calcium supplements. Routine iron oral iron prophylaxis given with ferrous sulfate 1 tab a day and full blood count monitored. My first question is to Dr. Jacinta Costa, consultant hematologist. Madam, when do thalassemia trait patients require blood transfusion? Hello. Next slide. Okay. If the woman develops symptomatic anemia, or if the fetus shows evidence of IUGR, you need to give blood. Again,
prior to delivery to optimize the hemoglobin level, blood transfusions are given if the hemoglobin level has not been raised up to a satisfactory level. Satisfactory level was taken as 10 grams per deciliter, and now people consider even a 9 gram or even 8.5 as satisfactory level in some circles. So we would like to ask our consultant obstetrician and also the physician about how your views on the minimum hemoglobin requirement.
I'll answer the part of the obstetricians. Now, I agree with Jacinta about the first requirement is the patient should be symptom free. If there is symptoms, then that needs time. So, but great majority of patients are symptom free. They are used to a low hemoglobin setting. And finally understand all hemoglobin is needed to deliver 10 millimeter of mercury oxygen partial pressure tissue level, mitochondria level. So as long as my mitochondria gets 10 millimeters of mercury partial pressure of oxygen, I'll be happy, whatever my carrying capacity and this and that. So in thalassemia, our understanding is supported by the book. Their oxygen delivery mechanism is much efficient than the normal person with normal hemoglobin, because they are used to that. The acidity, this and that, all things which you are the expert, is helping them to unload more oxygen. So therefore, in pregnancy, we will not say do things too much to get the HB up, but to keep it between 9 to 10. If it goes below 9, we make sure that we give either, say, several options to keep it between above 9. But in third trimester, when they are 32 to 34 weeks, we make sure that they will have 10, because we have no other proven method of 100% sure textbook level evidence to keep it any less and to have the problems of latter part of pregnancy of baby's growth, baby's requirement, maternal requirement, delivery, unpredictable amount of blood loss, this and that. Therefore, in latter part of the pregnancy, we make sure that it is so. Lastly, about the Jehovah's Witness, there is no clear-cut guidance wherever in the world about Jehovah's Witness. They will cover everything about the decisions of Jehovah's Witness under the carpet of multidisciplinary management. But finally, if the patient requires it, it is you. What are you going to do? So on and so forth. Read whatever the book, including how to face interviews, medical interviews. Nothing about serious, they'll say, be concrete about management of Jehovah's Witness in pregnancy with anemia.
In this patient, so she's a thalassemia trait. Now, if we forget about pregnancy, then of course up to 8.5 we can tolerate if the patient is not symptomatic, definitely. But in pregnancy, now if this is in first trimester of hemoglobin of 8.5, so it is very significant because it's to the low level. And in the second trimester and third trimester, there will be increase of plasma volume because of renin, angiotensin, and aldosterone system activation in that period. So anyway, there will be dilution of physiological anemia. So those patients, now if we take 10 as the normal cutoff for the normal pregnant patient, for patients with thalassemia trait, we could safely say 9.5, 9 or 9.5 would be all right. But other than that, we have to consider treating this patient. But having said that, we know that iron also toxic to the patient as well as to the fetus. So that's why the Australian guidelines, they don't advocate giving routine iron for their patients, right? They will assess the iron stores and then only they will consider giving prophylaxis doses or routine iron treatment. So these patients also, we have to consider that fact. Actually, if they can afford, we can go by assessment of the iron stores, right? Assessment of the iron stores, and if there's definitive objective evidence of iron deficiency, after assessing the iron stores, we can consider giving. Otherwise, we can go by the HP level.
Yeah, thank you. But it's just that it's actually regarding iron deficiency. WHO says that if your community prevalence is somewhat, say 40% or so, to give iron, and this iron dose that we give is not the treatment dose. It is just a maintenance dose of a daily maintenance dose. Treatment is different. We do not give the treatment therapeutic iron dose, iron therapy, unless the patient is diagnosed iron deficient. So that prevents iron toxicity. And even in thalassemias, there is a chance of it getting overloaded. We do assess the patient before giving iron. So minimum of levels are considered. And about blood transfusion, there is no cutoff to say thalassemic traits need blood transfusion. Anybody who develops symptomatic anemia, IUJR, and for the delivery should receive transfusions as appropriate.
Thank you, sir, madam. And moving back to our patient, she did not require red cell transfusion until term, but prior to delivery, her hemoglobin level was 8.5 grams per deciliter. So we gave 1 pint of red cell transfusion. And baby was delivered via normal vaginal delivery without any complications. No red cell transfusion required after delivery. And regarding screening of the baby for thalassemia, we usually do the screening at 1 year of age, because to diagnose thalassemia trait, we depend on the HbA2 level. And for it to be sufficiently expressed to be a diagnostic parameter, we have to wait until 1 year of age. Moving back to case number 2, this is a 21-year-old diagnosed patient with sickle beta plus thalassemia, sickle cell disease, sickle beta plus, and was referred to hematology unit at 10 weeks of PO in her first pregnancy. She has not been on proper clinic follow-up for sickle cell disease. A few words about sickle cell disease. It's one of the most common inherited disease worldwide, and clinical manifestations arise from the tendency of hemoglobin S to polymerize and deform red blood cell into characteristic sickle shape, giving rise to vascular complication. The Sri Lankan map is indicative of the distribution of patients of sickle cell disease in Sri Lanka. And there are 2 forms. First one is sickle cell disease. It includes sickle cell anemia, which is homozygous for hemoglobin S. And the second form is compound heterozygosity for hemoglobin S with other variant hemoglobin like S beta, SC, SD, etc. And the other one is sickle cell trait, which is the heterozygous form of hemoglobin S. Regarding S beta thalassemia, it is a compound heterozygous state of hemoglobin S and beta plus or beta naught thalassemia. In sickle beta naught thalassemia, there's no hemoglobin A, but in sickle beta plus, as in our case, there's a variable amount of hemoglobin A. And here the likelihood of sickling and the degree of hemolysis is lesser. My next question is to consultant hematologist, Dr. Jacinta Costa. Madam, what are the possible problems to be anticipated in a woman with sickle cell disease going through a pregnancy?
Next slide. There are various types of complications that can arise. The complications which are related to sickle cell disease are acute crises like acute chest syndrome, strokes, infections, and there are increased risk of pregnancy-related complications such as venous thromboembolism, hypertension, and then pregnancy morbidities like preterm deliveries and small for gestational babies, and treatment-related complications because these sickle cell patients are on hydroxyurea to increase HbF, and hydroxyurea is a teratogenic drug, therefore which should be withheld at the start of pregnancy. And there is also a risk of getting a child with a major hemoglobinopathy if the partner is also carrying hemoglobinopathy genes.
Thank you, madam. And moving back to our case, she has required occasional red cell transfusions and several hospital admissions due to painful episode, but there was no history of acute chest syndrome, stroke or any other thrombotic event. Her partner screening has not been performed. She was not on hydroxyurea or any iron chelator. And there was no significant other illnesses, no allergies, no history of transfusion reactions. There was a positive family history for sickle cell disease. And on examination, she was pale, mildly icteric, no lymph node enlargement, cardiovascular, respiratory, and nervous system normal. And abdominal examination did not reveal hepatosplenomegaly. On investigation, WBC and platelet counts were normal. Hemoglobin was 9.5 with low MCV, MCH, and normal MCHC. We did liver function, renal function, and UFR, which are normal. And also, her ferritin level was normal because she has required only few red cell transfusions during her lifetime. And we did the blood picture, which was compatible with sickle beta thalassemia, and there was evidence of hyposplenism. And as baseline, we did HPLC at the booking visit, which revealed a HBS percentage of 58% and compatible with sickle beta plus thalassemia. And we did viral screening, which were normal, and 2D echo was normal without evidence of pulmonary hypertension. We did blood grouping and antibody screening. She was ORHD positive. There was no significant antibodies detected. We did those both in booking visit and 28 weeks of POA. And we managed the patient in collaboration with the obstetric team, and we continued folic acid, vitamin D, and calcium supplements. As the serum ferritin was normal, routine iron supplementation given with monitoring of serum ferritin. And we gave penicillin prophylaxis as she had hyposplenism. And partner screening done. In the partner, there was no hemoglobinopathy variant or thalassemia detected. Patient and partner counseling done. And full blood count monitored initially monthly and 2 weekly at the latter part of pregnancy. And after thrombotic risk assessment, we gave thromboprophylaxis with low molecular heparin from 28 weeks of POA. And low dose aspirin started at 12 weeks and continued till 36 weeks for the prevention of pregnancy-induced hypertension because they are at high risk of that. And frequent fetal growth scan were performed from 24 weeks of gestation. And several blood transfusions were given during pregnancy due to symptomatic anemia. My next questions are to consultant hematologist Dr. Jacinta Costa. Madam, what are the indications for red cell transfusion in a pregnant lady with sickle cell disease? And when do they require exchange transfusions?
Next slide. The indications like previously, when the woman gets a symptomatic anemia, worsening anemia, when there are acute sickle cell disease complications like acute chest syndrome or stroke, or if the woman is on long-term complications to prevent sickle-related events like stroke or acute chest syndrome, and transfusions are also considered if there are obstetric indications to the fetus, and if the woman has multiple pregnancies, or if the patient had taken hydroxycarbamide early due to the severe disease, and when here now the hydroxycarbamide has been stopped, and here the HbF levels will drop, therefore the patient might need transfusions. Next slide, please. Exchange transfusions are done when there are acute situations to reduce the HbS level to less than 30%. Now our patient also has a HbS of something like 50 odd. Yes. If the patient gets acute complications like acute chest syndrome or stroke or thrombosis, or if the patient is going for a surgical procedure and now already has a hemoglobin of more than 9, then you are not going to give another transfusion over it and make the patient polycythemic or positive, because that is something we should not do. And that such situations, extended transfusions are required.
Thank you, madam. Then few words about specifications for blood transfusions in sickle cell disease. We have to give ABO compatible. There are clinical significant red cell blood. At 26 weeks of POA, she admitted with bilateral leg and back pain for 2 days, and we managed as a painful episode. We gave paracetamol and tramadol as pain relief, good hydration, incentive spirometry given, and thromboprophylaxis given with low molecular weight heparin during the hospital stay. And at that point her hemoglobin was 7.8, which is less than her baseline hemoglobin, so we gave 1 unit of top-up red cell transfusion. And this patient had no issues regarding positioning for vaginal delivery, like avascular necrosis of hip, and also there were no obstetric indication for section, so we planned normal vaginal delivery. As hemoglobin level was 9.5 grams per deciliter with a hemoglobin S of 55%, we gave a single exchange transfusion and normal vaginal delivery done with epidural analgesia, and good hydration and warmth maintained throughout, including pain relief, and a normal healthy baby delivered with no neonatal jaundice. Thromboprophylaxis we continued during the hospital admission and postpartum 6 weeks. And baby was planned to screen for hemoglobinopathy at 1 year of age, although the hemoglobin, the screening for sickle cell disease can be done at birth also, but for the confirmation we have to wait until 1 year of age. And we educated regarding her contraception and plan of next pregnancy. These are my references, and thank you very much for listening.
I'm Dr. Punsa Sineshankar, Senior Registrar in Clinical Haematology from Colombo North Teaching Hospital. Welcome all of you to the last clinical case discussion of Anemia Symposium. And in next 20 minutes and so on, you're going to be with the story of Mrs. P. Mrs. P, a 41-year-old lady, P3C2 mother, referred to hematology clinic from antenatal clinic at 26 weeks of POA with hemoglobin of 7.2 gram per deciliter. And she was on hematinics with good compliance. She's a diagnosed patient with type 2 diabetes mellitus for 8 years duration, and she was on oral hypoglycemic drugs, but she had poor compliance and defaulted clinic follow-up. Her antenatal clinic attendance at MOH clinic was also poor. So she was referred to the obstetric unit of a tertiary care hospital for further management of pregnancy, which is complicated with diabetes mellitus and anemia. Further evaluation of history revealed bilateral lower limb swelling for fast 1 week duration, exertional even with mild exertion, and chronic proteinuria. But there was no hematuria, no clinical features of heart failure, and blood pressure remained within normal limits, and there was no clinical features of preeclampsia. Dietary history was satisfactory, and there was no bleeding manifestations. On examination, she was pale, had bilateral lower limb edema, there was no murmurs, knee-jerk examination was normal, symphysiofundal height was 22 cm, which was less than the POA. We did further investigations and they revealed evidence of proteinuria, evidence of renal impairment with EGFR of 37 milliliter per minute, and ultrasound scan abdomen revealed poorly demarcated corticomedullary junction of both bilateral kidneys, and also eye referral detected to have retinopathy. So we came to a diagnosis of chronic kidney disease, most probably due to diabetic nephropathy. So, in summary, this is a 41-year-old P3C2 mother at POA of 26 weeks with comorbidities of long-standing diabetes mellitus, newly diagnosed diabetic retinopathy with proteinuria and anemia, having despite good compliance to hematinics. So my first question goes to consultant physician. Dear sir, what would be the would you please outline the medical management of this patient?
Yeah. So this is basically a patient with type 2 diabetes having for 8 years. And I think this patient's management should start before conception. Now you said that patient was on oral hypoglycemic drugs before conception. So only the anti-diabetic we recommend while patient being pregnant or getting pregnant is metformin. Or else, if we can't control blood sugar with metformin alone, then we have to start on insulin. So that's a very important take-home message. If the patient is willing for a type 2 diabetes patient is willing for a pregnancy, put them on correct pharmacological therapy for type 2 diabetes. Now this patient is having complicated diabetes with diabetic nephropathy, having a stage 3 renal failure. And for stage 1 renal failure, there can be about 10% of patients can have anemia. And for stage 3, there can be 33% of patients can have anemia. So this patient, as you can see, the patient is also anemic. Probably this could be due to iron deficiency anemia or erythropoietin deficiency. So this erythropoietin deficiency may be due to anemia of chronic disease. In this scenario, there's no specific treatment with regard to medical management. If this patient is not pregnant, what we manage is the correct blood sugar control and optimum control of lipids and blood pressure, and then avoid nephrotoxic drugs or nephrotoxic any other medication, and good hydration, which is very important. So for these patients, blood sugar management wise, of course, the blood sugar management we go, our target levels are less than population. I mean, the fasting blood sugar we expect to have is 95. In a normal patient, it is less than 130. So usually once the patient is pregnant and have diabetes, so blood sugar control we get them to optimum control with metformin. If we can't do that alone with metformin, then we will go with insulin also, right? And no other oral medication. So the newer current guidelines suggest use of insulin before starting metformin, but in our setup it's practically difficult. Then the patient should have self-blood sugar monitoring at home and glucose monitoring machines and strips and those things. And for blood pressure, now these patients have a high risk of developing preeclampsia. So because of that, it is recommended to give aspirin 150 mg after 12 weeks of pregnancy up to 36 weeks. That is evidence-based to prevent preeclampsia for these patients. Now, if this patient is protein signature proteinuria. If this patient is not pregnant, we would have to reduce the proteinuria. But inhibitor is definitely contraindicated during pregnancy, and ARB is also contraindicated. So because of that, we can't use either of them. So if the patient is having developed any hypertension, I would prefer, rather than giving calcium channel, giving nifedipine or amlodipine, to give diltiazem. Because non-hydropyridine calcium channel blockers can cause increase the protein urea, but diltiazem would be less, right? So those are the things that we will consider, and we will ask her to make hydration and avoid. We will regularly monitor her blood sugar control, diet control, which is very important. And most of our patients, they have lack of exercise. After getting pregnant, they tend to, have a sedentary kind of life, have more energy to their diet. So we will get them to the medical nutrition therapy as well, which is very important. So all those things should go hand by hand. So then we will try to get her through the pregnancy. After that only, following postpartum period, we will start. Now, early it was not recommended to give ACE inhibitors in lactation, but now it is recommended. We can start ACE inhibitors after delivery.
Thank you, sir. Further evaluation. Myelofibrosis, leukemia, or lymphoma, and reticulocyte count remain within normal limits. So, what can be the possibility of anemia in this patient? One is the anemia of chronic disease, other is the absolute iron deficiency. So, anemia of chronic disease or anemia of inflammation is associated with the state of chronic inflammation. If I discuss briefly about pathophysiology of anemia of chronic disease, functional iron deficiency plays a major role in anemia of chronic disease. And apart from that, early erythroid precursor cell death, erythropoietin, reduction in erythropoietin production, as well as reduced erythropoietin sensitivity, and contributing factors from underlying disease also plays a role. Apart from above mentioned factors, anemia of chronic renal disease, blood loss during hemodialysis, uremia-induced red cell survival, myelodysplasia, ineffective erythropoiesis, and platelet dysfunction leading to bleeding also contributes for anemia of chronic renal disease. So, functional iron deficiency is a state where insufficient iron incorporation into erythroid precursors in the presence of adequate body iron stores. So, how can we assess the iron status in our patient? One way is by doing iron studies. Iron studies are comprised of serum ferritin, serum iron, total iron binding capacity, and transferrin saturation. As doctors, we all have to know regarding the requesting for iron studies. It is a serum sample, and it is has to be collected to a plain tube, and it is preferred a new plain tube or acid wash tube. And early morning sample is preferred because serum iron is highest in the morning, and as it shows a diurnal variation. And also it's important to mention about the transfusion history and IV iron transfusion history in the request form for interpretation. So, serum ferritin is a protein-bound tissue iron storage, and a small proportion of this iron storage leaks into the plasma, and here we measure it as serum ferritin. So, in health, there is a direct relationship between the iron stores and serum ferritin. So, it is a good indicator of stored iron. But serum ferritin is an acute phase protein, so this level rise in response to inflammatory states. So, if the patient is having any clinical or laboratory evidence of inflammation, need to investigate further for iron deficiency despite having a normal ferritin level. Another way of measuring iron incorporation into developing erythroid erythroids is advanced or the novel red cell parameters. One is the percentage of hypochromic red cell percent. If it is 6 or more than 6, that is indicative of iron restrictive erythropoiesis. And other one that is the best parameter. And other one is the reticulocyte MCH. If it is less than 29 picogram, or the reticulocyte hemoglobin content, if it is less than 25 picogram, those are indicative of iron restrictive erythropoiesis, or the deficiency of iron incorporation into the developing erythroids. Further investigation to differentiate whether anemia of chronic disease or iron deficiency in our patient. So we did see iron studies as well as reticulocyte hemoglobin content. So my next question goes to consultant hematologist. Dear madam, what would be the most likely reason for her anemia?
Okay, the ferritin level of this patient is 150. So you see that it is more than the reference range. But the patient's CRP is also somewhat elevated. So as you described earlier, ferritin is an acute phase protein. And with this rising CRP, maybe the ferritin level is falsely elevated. So at this point, it is very difficult to say whether the patient is actually having any iron deficiency in this patient. Definitely seems to be having anemia chronic disease, but we cannot say whether the patient is having an associated iron deficiency or not, because the CRP would have falsely elevated the ferritin level. Then taking the serum iron and the total transferrin saturation level, both these parameters are reduced in anemia chronic disease and iron deficiency, so those parameters are not of use. Total iron binding capacity of our patient this is very important parameter that can be used to differentiate between anemia chronic disease and iron deficiency. Total iron binding capacity, as you know, is elevated in iron deficiency and reduced in anemia chronic disease. In our patient, it is reduced. So most likely, so this confirms the diagnosis of anemia chronic disease. And the reticulocyte hemoglobin content of our patient is also low. So that means the patient's reticulocytes have lesser amounts of hemoglobin. Therefore, it seems as if with sufficient amount of iron, the patient has not produced adequate amount of hemoglobin. So appears to be our patient appears to be having a functional iron deficiency or iron restrictive erythropoiesis.
Yeah, can I
Yes, sure.
Can I add to that? Now there are cutoff values. Now in iron deficiency, in anemia of chronic disease, which is inflammatory anemia, the serum ferritin level expected to be more than 100. So this is 150, so that is suggestive. But the transferrin saturation is 14%, where they say with renal failure, transferrin saturation, if it is less than 20%, it is suggestive of iron deficiency. So she is having both, probably iron deficiency and inflammatory anemia as well. So there's iron deficiency and erythropoietin deficiency also. Both are there probably. That is another possibility in this patient.
So the problem is these cutoffs of 150. Usually, when it is goes past above 150, it is unlikely to be iron deficient according to the latest guidelines. But those are on non-pregnant ladies. Yeah. So in this situation, it is somewhat difficult where nobody has given exact cutoffs as such.
Yes. Yeah. So we have to take it from clinical context. Yes.
Thank you, sir and madam. If I briefly outline the management of anemia of chronic disease, it is the treatment or the optimization of the underlying disease status and the supportive care with red cell transfusion, erythropoietin treatment, and iron treatment. And so many trials have proven that IV iron is better than oral iron. And also to correct the underlying nutritional causes if there is any. So, for the antenatal care of our Mrs. P, we managed her with supportive care with red cell transfusion and IV iron transfusion. And we did serial growth scan monitoring, and hemoglobin was maintained around 10 to 10.5 gram per deciliter, and the diabetes mellitus and the renal impairment was optimized with medical management. So she delivered at 37 plus 5 weeks of POA by normal vaginal delivery, and the delivery and the postpartum period was uncomplicated, and she was contraception was planned, and medical follow-up arranged for diabetes mellitus and renal impairment. With that brings to the end of my presentation, and these are my references, and thank you.
There is one question that came up in the chat. I'll read it out of the head table. Madam, sir, if there is one question, when to assess the response to parenteral iron treatment?
Cool. In 2 weeks' time?
Okay, so the short answer is 2 weeks. There is another question that we'll probably take up in the thrombosis symposium. Are there any other questions from the audience?
Can I
Yes.
do one remark? You all kept on saying blood transfusions. The blood transfusions are not just blood transfusions. Now, blood transfusion, you must differentiate of giving once in a while blood transfusion and repetitive blood transfusions. And repetitive blood transfusion sometimes not only on this occasion and future occasions too. So specify the blood transfusion variety, right? We have not only just plain blood, we have leukodepleted blood, and we have washed red cells. So people who are going for this type of things, right, we give the best, the washed red cells, right? The transfusion specialists may think you are smart, but insist. That is how we manage. And understand there's something called the graft versus host reaction, right? Baby is there and you are giving others blood, white blood cells, can have reactions. So unless it is, say, very latter part of the pregnancy and one off and on blood transfusion, now as hematologists, you all should be more specific, supportive to us. Thank you.
Yeah, sorry about that, Pradeep. Yes, our blood transfusions meant red cell concentrates, and whereas these thalassemics or sickle cell patients would be leukodepleted because they will go on getting repeated transfusions. Graft versus host disease prevention is for, to prevent it, you need to get it irradiated. So that kind of extent we do not go unless there are clear indications for that. So those are followed according to this. The normal pregnancies or some amount of low HP, we would not go to that extent. Okay, thank you very much for all your interesting questions.
Madam, there is one more question, probably directed to the obstetrician. Can we give COCP, I think, combined oral contraceptive using postpartum sickle cell anemia patient for contraception?
Now, contraception, now you must first think how long she is going to breastfeed the baby. So breastfeeding will contraindicate giving oral contraceptive, right? Not actually, but it's mostly. Understand the testis is working for the first 2 years of life after birth, right? And if you give oral contraceptive pill, the mother will secrete estrogen in big amounts in her breast milk, and the effect of that on the establishment of the hypothalamus-pituitary testis, this thing could be affected, and this may be the cause of having too many deviations deep, right? So that is one absence. If not, she's not breastfeeding. If the hematologist are
Move on to the next symposium. That would be the bleeding symposium. First presenter would be Dr. Jayanti Kavantan. He will talk on how to protect the endometrial procedure. Second presenter would be Dr. Professor Pramila. The journey with contraceptive fragmentation syndrome in pregnancy, type or
protect the endometrium in a bleeder. For that, I have taken one of our clinic follow-up patient who is a 16-year-old teenage girl with type 3 von Willebrand disease. So managing her menorrhagia is quite challenging for us as well as to the gynae team. So let's move into the case. I would like to start the history from the beginning. So she was born by normal vaginal delivery, no antenatal or postnatal complications. She is a second child of non-consanguineous healthy parents. When you're getting a history from a bleeder, a birth history is quite important. So I have to emphasize here, we have to ask 4 main points when you're getting a history during the birth. So whether patient had any cephalohematoma or umbilical stump bleeding, cheek bleeds, or any other skin or mucocutaneous bleeds. So she was perfectly all right until the age of 2.5, and at the age of 2.5, she presented to the hospital with excessive bleeding after cut injury, which warranted hospitalization and suturing. Her mother denies a history of any hemostatic challenges in the past. No family history of any bleeding disorders. She was not on any medications. On examination was perfectly all right. So let's move on to the investigations. In a bleeder, doing a full blood count is vital to check the platelet count. Her blood picture shows normal platelet morphology. So we went ahead with coagulation profile, which shows APTT of prolongation of APTT, which is get corrected with 50-50 mix with normal pool plasma, which confirms the factor deficiency. Here you all can see we did bleeding time, which is no longer widely done in Sri Lanka because it's operator dependent and cumbersome to the patient. So then we went ahead with factor assays and von Willebrand profile. Factor 8 levels is markedly low, it is less than 1%, together with very low von Willebrand factor Ricoff activity and von Willebrand antigen, we made to a diagnosis of type 3 von Willebrand disease. So at the age of 10 years, until the age of 10 years, she never had any spontaneous or traumatic bleeding manifestations until she attained the menarche at the age of 10. So she presented to us with menorrhagia, which is heavy and prolonged, causing anxiety to the patient as well as to the parents. Her full blood count shows a HB of 8 with evidence of iron deficiency. So my first question goes to Dr. Gunawardena. Madam, what are the important points in a history in a bleeder?
Yes, what I like to point out here is that bleeding is a very common symptom across the general population. So if you go to screen each and every bleeder, that's not going to be cost effective, particularly in the current setup. So to overcome this, we need to have a proper tool to detect who we are going to screen. So to do that, there are some scores that have been derived to pick up the important ones who will be having a bleeding disorder, and that is called the BAT score, bleeding assessment tool. Things like diseases like von Willebrand's disease can have type 1 von Willebrand's is extremely common. So you need to apply the BAT score, and if the BAT score is over 3 in a child or over 6 in a female, we would proceed on for further investigations. This is to pick up the important ones. So if you go to the next slide, so for menorrhagia, these are the points. Now our patient at 2.5 years also had a BAT score of 3 where she bled and she was taken to the hospital for suturing. And in case of menorrhagia, also she had a BAT score of 4 where she was hospitalized, blood transfusion was given. So she's still a child, so less than 18 years, a BAT score of 3 would warrant further investigations in a bleeder screening profile. So history is extremely important. I'm sure you're familiar with the PABG score where you assess the significant amount of menorrhagia with the totaling of the score. So I won't go into detail of that. So I'd like to highlight that history is the most important component of a bleeder in arriving at a diagnosis before going on to specific tests.
Thank you. Second question is again to you, Dr. Gunawardena. What are your recommendations for her bleeding in the background of von Willebrand disease?
Yes, let me tell you a bit about von Willebrand's disease. So this is the commonest bleeding disorder worldwide, right? And they do present with mucocutaneous bleeds. And there are three types. Actually, women are more likely to come to medical attention. Men and women are equally affected, but we see women more often because they come with gynecological and obstetric bleeding. As I said before, there are three types. So you might wonder, being the commonest bleeding disorder, why don't we see them? So one of the reasons is that type 1 is the commonest. And of course, they present as mild bleeding. So they may present with menorrhagia later on. So they do not have significant bleeding. So the exception is type 3. That's our patient, right? Type 3 would have very significant life-threatening bleeding because their factor levels are also extremely low, as well as their von Willebrand levels. So therefore, they present as severe bleeding, life-threatening menorrhagia, and for some reason, it's commoner in the Asian population, and we do, hematologists do manage quite a few von Willebrand disease girls with life-threatening menorrhagia. So this will be a problem where you might have to So for this patient, tranexamic acid, as we all know, it's a very useful agent to control bleeding. So we can give IV 1 gram 3 times a day. Intermediate purity factor 8 is what is recommended because that has von Willebrand factor and factor 8 both, right? It is fortunately currently available, but I don't know with the current situation whether we'll be able to have a continuous supply of this, which is quite a challenge in the future. So we can treat the iron deficiency, because that part you might ignore, because most of these patients are iron deficient and you need to treat them with iron. And of course, for severe anemia, symptomatic anemia, she will be given a blood transfusion, and of course, gynecological referral is a must at this stage.
Right. My third question goes to Dr. Madhura Jayawardena. How would you support the endometrium in this girl with the background history of von Willebrand disease?
So, to add to Madam's assessment, actually, the patients initially come to gynecologists, and it's a very common thing for a young girl to have heavy menstrual bleeding or bleeding irregularities when they attain menarche, and immediately just after it, and mostly it's due to annular cycles. And it is, you need to have your red flag going on when someone is not responding to initial management of simple tranexamic acid, and someone is not needing admission to a hospital. Young girl, just don't ignore, and then that's the time that you need to refer to a hematologist to investigate her further for bleeding manifestation. And that is the commonest way that we detect bleeding disorders in young girls, because we tend to ignore because they're thinking that that's in annular cycles. Okay, that's an important point that all gynecology trainees needs to keep in mind. And then to support the endometrium when someone is having bleeding disorders. So as Madam said, we initially start with simple forms like tranexamic acid 1 gram TDS, and if they are not responding, the next best option for them is to start them on combined pill. It is, we are taking the pill action on the endometrium, which thins out so that their bleeding is less. So that's the next step.
Right. Thank you. So in spite of the mentioned hematological and gynecological management, she continuously experiencing heavy bleeding. So it brings anxiety and discomfort to the patient as well as to the parents. So my next question goes to hematologist as well as to the gynecologist. What is the next option for her at this stage? We'll start with hematologist.
Yes, so at this time, actually, it was a nightmare managing her because she was extremely anxious, worried. So tranexamic acid, just like what we discussed before, factor correction to 50% with immunate. And now at this point, it was such a dilemma because we didn't know how to control her bleeding, and we also were very anxious because, you know, suddenly she would come in the middle of the night with HB of 2 or 3. And so at this point, we were in fact thinking whether this is the place to start on prophylaxis. So prophylaxis would be maintaining a satisfactory level of factor 8 and 1 milligrams through continuous infusion, like say once a week you infuse for about 6 months. So these are all recommendations. So in fact, we were thinking whether we could give prophylaxis at least to cover her menstruation time. The recommended prophylaxis would be continuously, but at least to cover during menstruation. So we did do that for 6 months, and unfortunately, this didn't help either.
Right, thank you. What would be your next step at this stage?
If someone is not responding to combine oral contraceptive pills and tranexamic acid, there is a place for high dose of progestogens for her. I think initial easy way of starting is to give her oral progestogen, something like noitestrone, which is commonly available and cheap, so that we can give cyclical noitestrone for few months and see whether she is responding. I think if she's responding to that, then we can continue it for a long time. And then there are other forms of progesterone delivery system that we have, which reduce the hassle of taking it every 2-3 times per day for a long time, like progesterone implants are available, subdermal implants and intrauterine devices are available. Those things can be explored. But when you using intrauterine implant into a young girl who is unmarried and a virgin, you need to think several times and decide on that.
Thank you, sir. So next question is again to you. In spite of hematological and gynecological management, she was continuously having menorrhagia. What is your next option for her? So finally
we can move on to more radical options, but then still it's much better if you are going for in this young girl to spare the endometrium and the uterus. So obviously the last option would have been to take off the uterus or even to do other uterine preserving procedures, still like endometrial ablation or resection, that we can do that will reduce the amount of bleeding. But still, after those procedures, future pregnancy desires will disappear. So I think in this patient, then there would no option but to try for a intrauterine system, which secretes produce levonorgestrel.
Right. Thank you, sir. So we went ahead with the Mirena coil insertion. With that, she was doing quietly well. She has getting her regular periods, and there were mild spotting in between without needing medical attention. So 6 months later, at the age of 16, she admitted with fever, abdominal pain, and vomiting for 2 days duration. She didn't have any focal symptoms, no history of bleeding manifestation. On examination, she was severely pale and there was a mild abdominal tenderness. Apart from that, other examination was perfectly normal. So investigations showed the HB of 4.8 and the blood picture confirmed the finding. There's evidence of iron deficiency with evidence of active bleeding. Her reticon was 5% and bilirubin was normal. CRP was less than 5, UFR was normal, dengue antigen and antibody were negative, liver function was normal. So then we did ultrasound scan of the abdomen, which showed the normal uterus with moderate amount of echogenic fluid noted in the abdomen and pelvis, free fluid in hepatorenal pouch and splenorenal pouch. There was a ruptured corpus luteal cyst in the right ovary. So we repeated the scan in 3 days' time, which showed 3.2 into 2.6 into 3.7 centimeter heterogenic echogenic area, more likely hematoma in right adnexia or hemorrhage into a right ovarian cyst. There was a mild free fluid in pouch of Douglas and upper abdomen. So we managed her with 3 blood transfusion, IV tranexamic acid and immunate. Initially we gave 50% correction, 12-hour interval for 3 days, followed by 30% for 2 days and 20% for a day. At the same time, we did a gynecology referral. So they are not going to do an active intervention. They asked to suggest norethistron 5 milligram TDS. So at this point, again, the question goes to Dr. Madhura Jayawardena again. So why did she give corpus luteal cyst, rupture, and bleeding while on Mirena coil?
Okay, it's a again nightmare situation. Now we kind of manage heavy menstrual bleeding. Now she's starting to bleed from elsewhere. Now, if you think again, what Mirena does is Mirena exerts its main action on the endometrium and on the cervical mucus, and it does not suppress ovulation, and it's not commonly suppress ovulation. I think more than 50% of the time, a woman on a Mirena will have less bleeding, or even she goes into amenorrhea, but while she is ovulating. So therefore, that's why she ovulated. Mirena is, I mind you, like it's a primary lip. Its action is on contraception. So its main action is on cervical mucus and endometrium. So I think she will be better off by adding on top of Mirena, because she's responding well to Mirena, where we are giving her only progestogens. If we can add some estrogen, it will create a little bit of cycle control as well. And combined oral contraceptive pill, its main action is on ovulation suppression. So I think it will help her in dual ways. Reduce the bleeding further, plus it will suppress the ovulation as well. So we might be able to hold ovulation and corpus luteal bleeding. And the other problem with Mirena is, if you go through the literature, its common side effect would be to have a functional ovarian cyst. Because of Mirena itself can have a functional ovarian cyst, which is seen, I think, about 30% of the time when you put a Mirena, you will get a functional cyst. Usually in normal women, we don't need to do anything. It will disappear in about 3 to 4 months' time. So those things would have added to her current presentation. I think the next step forward would be to add on top of Mirena, while keeping the Mirena intact, add some combined oral contraceptive pills. I think it will benefit her.
Right. Thank you, sir. Hope you have answered my second question as well. So during the follow-up, we saw her in a month time in a clinic. She didn't have a complaint of menorrhagia. She's getting regular periods and her HB was all right. So then my next question goes to hematologist, Dr. Gunawardena. What is the role of factor prophylaxis during menstruation?
Yeah, actually, now we were quite okay to manage her menstruation, but knowing very little about gynecology, we didn't anticipate a bleed from the corpus luteum. You know, the patient comes and the mother says there was no vaginal bleeding and her HB is 4, and we are wondering from where she's bleeding. So to see that there is corpus luteal bleeding, which is even a bigger nightmare, because we never know when she will ovulate. And as Madhura suggested, now the next line of action would be to stop ovulation as well, isn't it? Yeah, so now it's quite a dilemma actually. We got some opinion from an expert as well, but he also says that prophylaxis per se would be a challenge, particularly now we might not be able to kind of have a continuous supply of immunate. So those are all issues, but I think it might be a good idea to see when this patient is ovulating. Madhura, is it possible with ultrasound?
We can keep doing the follicular tracking, but there is it's not 100%. So yeah. I think one way, if we are really go out of immunate, and if we are to give it during menstruation, that's a viable option, just to bring her down somewhere around, provided she's having regular periods, bring her down in about day 10, 11 of a cycle and see whether there is a follicle, and if it is maturing and we think it's ovulation, you tend to ovulate, like if it is more than 17 millimeters, I think that time we can cover to save the immunity. If not, there should be a baseline level of immunity, and then we can go ahead like.
Yeah, so I think that we do have a clear plan now, so we'll see how feasible it is.
Right. Thank you, madam, and thank you, sir. Again, the next questions to you, sir. How will you treat her bleeds when she's planning her pregnancy? It's quite challenging.
Yeah, it's going to be a nightmare. So it's very important to counsel the patient from the beginning. Now she's still young. I mean, there are so many options rather than getting pregnant, because we know pregnancy and childbirth is a high risk for bleeding, and this girl is definitely going to be under that category. So if she's really want to get pregnant, we like manage the pregnancy as usual, but there are like primary basic things that we need to maintain, like keeping optimal level of hemoglobin so that we can prepare her for the bleed that she's about to get, hopefully during the delivery time. And of course it's going to be a significant multidisciplinary effort managing her labor especially, and hopefully she would have a normal like vaginal birth so that the bleeding will be minimized. And then there are things that we do to prevent postpartum hemorrhage that we need to go ahead and do, like active management of third stage of labor. And then if she start bleeding, then we need to fully go to manage the postpartum hemorrhage as usual. And definitely there would be a place of factor replacement in this patient during that time. Yes.
Thank you, sir. That's bring the end of my presentation. Thank you for listening.
Good morning, all of you. I'm Dr. Sashprabha Seneviratna, Senior Registrar in Clinical Haematology from Colombo South Teaching Hospital. During next 30 minutes, I'll be discussing about a lady who has a journey with thrombocytopenia. She was an 18-year-old primary who was referred from antenatal clinic visit to us due to incidental detection of isolated thrombocytopenia at 10 weeks of gestation. Rest of the history and examination was unremarkable. We did repeat full blood count, which showed isolated thrombocytopenia, and it was manually confirmed on the slides. And spurious causes for thrombocytopenia, like EDTA-induced platelet clumping, was excluded. My first question goes to Dr. Chandima Kulatilaka, consultant hematologist. Madam, what are the causes of thrombocytopenia in pregnancy?
Yes, thrombocytopenia defined as the platelet count below 150,000 in pregnancy has many causes and definitely needs further evaluation. So when we take the causes, there are pregnancy-specific causes, especially isolated thrombocytopenia caused by gestational thrombocytopenia, which accounts for about 75% of the cases. And again, hypertensive disorders such as preeclampsia and HELP account for about 15 to 20% of the cases of thrombocytopenia in pregnancy. Then there is a set of causes which has no relationship to pregnancy, but there are like causes such as thrombotic microangiopathies, which shows increased frequency in pregnancy. But in this pregnancy non-specific causes, primary autoimmune thrombocytopenia, that is ITP, which is again isolated thrombocytopenia, comes as an important cause, which accounts for about 3 to 4% of cases. Yeah, if I highlight the onset of thrombocytopenia previous slide, Sashi. Yeah, so if I want to highlight the onset of thrombocytopenia in pregnancy, the important causes, we have to keep in mind that gestational thrombocytopenia, it's an isolated thrombocytopenia, occurs in the latter part of pregnancy, usually from mid-second trimester to third trimester, right? Important cause in third trimester. Then primary autoimmune thrombocytopenia, ITP, is the commonest cause in early pregnancy, usually in first and second trimester, but there are causes in third trimester as well, right? So those are the two important causes of isolated thrombocytopenias, and other causes such as hypertensive disorders and microangiopathies usually occurs from the second trimester onwards.
Thank you, madam. Could you please tell us how do you evaluate thrombocytopenia in pregnancy?
Yes. Now, yeah, first thing is confirmation of thrombocytopenia, as Sashi mentioned. So in a case of confirmed thrombocytopenia, like in a non-pregnant female, it is through evaluation by history, examination, and the laboratory workup. So in a pregnant female, there may be readily available clinical evidences for a diagnosis of a hypertensive disorder or a microangiopathy. In such case, there will be straightforward laboratory workup. But in the absence of that, say it's isolated thrombocytopenia, like in a normal pregnant, the history should include the questions, important questions like the association of a recent febrile illness, other autoimmune manifestations, previous history of pregnancy-associated thrombocytopenia, or previous pregnancy unrelated thrombocytopenia, neonatal thrombocytopenia, as well as neurological manifestations and family history of bleeding manifestations. And examination include blood pressure examination and lymphadenopathy and organomegaly. The extent of the laboratory workup actually is dependent on the clinical evidence and the findings of the basic laboratory workup. So basic laboratory workup is more or less similar to a non-pregnant female, but we with special consideration of pregnancy-associated conditions like hypertensive disorders and microangiopathies. So so these are the recommended basic tests. And so depending on the basic test, we further evaluate the other causes.
Okay, thank you, madam.
Yeah, so just to give emphasis on two important cases of thrombocytopenia, because we encounter these two conditions and they share. So gestational thrombocytopenia, as I said previously, it's the latter part of pregnancy, usually causes a thrombocytopenia below, rarely causes a thrombocytopenia below 70,000, right? It's a mild thrombocytopenia between 100 and 150,000 most of the time. And it's not associated with usually not metabolicity and not associated with count can go below 50,000, and it's associated with fetal thrombocytopenia. So there may be diagnostic challenges between these two conditions, especially in the latter half of second trimester and in the third trimester. So you have to keep that in mind.
Thank you, madam. Moving into our patient, as madam clearly said, we started with a blood picture to confirm thrombocytopenia and exclude other differential diagnoses. Blood picture, the red blood cells were normochromic normositting and there were no fragmented red cells. White blood cells were normal. blood picture revealed only isolated thrombocytopenia with large and giant forms. Rest of the laboratory workup was done where ESR, coagulation profile, liver, renal, thyroid functions were normal, viral screening and ALT were negative, and ultrasound scan was normal. In the absence of atypical findings during clinical evaluation and
and which readily shows no evidence of thrombotic microangiopathies, and showed in this case showed giant platelets, right, which are in favor of immune thrombocytopenia. So in the management, it's definitely a multidisciplinary team approach with the involvement of the VOG, obstetrician and gynecologist, the consultant anesthetist, neonatologist, and the hematologist. And management focuses on antenatal management, the management of delivery, and management of the baby. So the main goal, or the target during antenatal period is to achieve and maintain a safe platelet count rather than a normal platelet count, right? And yeah, most of the times the decisions are taken, although the guidelines are there, they're taken on individual basis, right, depending on the platelet count and the bleeding manifestations. And also the management decisions depends on urgency of the platelet increment, the duration of the increment required, and the potential side effects. So in this patient, as this is an asymptomatic patient with no bleeding manifestations, there's no planned invasive procedures, the platelet count is more than 30,000. So we just keep the patient without any interventions, and this will be safe until about 36 weeks. The monitoring part is important. So generally we advise monitoring of 4 weekly counts until about third trimester, but definitely we have to increase the frequency from third trimester onwards, as there is a tendency for the ITP counts, platelet counts, to drop or decline during third trimester and towards term. So we have to increase the frequency of monitoring. Even in the previous trimesters, depending on the individual case, frequency of monitoring will vary.
Thank you, madam. As madam clearly said, our patient, there was no indication for any hematological intervention. So we arranged hematologic clinic follow-up to monitor count. After 2 weeks, at 12 weeks of gestation, her platelet count dropped to 25,000 per microliter. It was confirmed with repeat full blood count, and blood picture showed only isolated thrombocytopenia with large and giant forms. Madam, what is the hematological management of this patient at this stage?
Yes, so unfortunately she has presented with a low count, which is lower than the 30,000. She didn't have any bleeding or any invasive procedures. But anyway, because of the low count, less than 30,000, the management options would be oral corticosteroids and or IVIG, which are recommended as first-line treatments in pregnancy. So usually we go for the oral corticosteroids. Remember, it's different from non-pregnant values. It's a lower dose that we are giving in pregnant females. And IVIG is considered if rapid response is required, maybe impending close delivery, awaiting invasive procedures. And there's a place for a combination of IVIG, methylpred, and platelet transfusions in life-threatening bleeding situations.
Thank you, madam. Moving back to our patient, as madam said, we started her on low-dose oral prednisolone, 30 milligram daily. With that, patient's platelet count was increased to 150,000 per microliter, and then we started gradual tailing off of prednisolone. But During this tailing off of prednisolone, patient developed diabetes mellitus, probably due to steroid induce. Continuing with the follow-up, at 16 weeks of gestation, her platelet count dropped again to 15,000 per microliter. At this time, patient was complaining of mucocutaneous bleeding, mainly gum bleeding, and her prednisolone dose at this moment was 50 milligram daily. Madam, now how would you approach this situation?
Yeah, I guess there may be different opinions from the hematologists, even in the audience. The management strategies may vary among the consultants approaching this case. Rationally, yeah, maybe that as the patient's response to steroids well, you can go back to the previous starting dose of 30 milligrams and maybe add tranexamic acid because of mucocutaneous bleeding. So if you are really worried about the mucocutaneous, I don't think so. Yeah, you may consider the addition of IVIG.
Thank you, madam. We have given 1 dose of IVIG and resumed the prednisolone 30 milligram per day dose, and with that platelet count was maintained 30 to 80,000 per microliter, and we started slow tailing off of prednisolone with blood sugar monitoring. At 28 weeks of gestation, during tailing off of prednisolone, there was a sudden drop of platelet count from 75,000 to 20,000 per microliter. At this moment, her prednisolone dose was 15 milligram per day. Madam, now what are the treatment options would you consider on this patient?
So again, yeah. Pregnant female, there are so many options actually. So we might consider second. But unfortunately, in pregnancy, our options are very limited. So most of the drugs are either contraindicated or not recommended for the use in pregnancy. So first line drugs would be, as I previously mentioned, IVIG or corticosteroids, and there are instances that we go for combination of therapy, IVIG and corticosteroids, depending on the urgency or the need, right? So in this patient, yeah, you may consider IVIG or considering the diabetes state as well, if there is a good glycemic control. I might even go for an increased dose, maybe a non-pregnant dose for platelet count increment, an expected platelet count increment.
Okay, madam, thank you. Her glycemic control was good with oral hypoglycemic drugs, and so we increased the prednisolone dose to 50 milligram daily, which is 1 milligram per kg daily dose, with the aim to maintain platelet count more than 30,000 per microliter. And platelet count was maintained around 70 to 80 into 10 to the power 9 per liter, and we started gradually tailing off of prednisolone with close monitoring of platelet count as well as the blood sugar. To make the things worse, at 34 weeks of gestation, her ultrasound scan revealed placenta previa grade 1, and her platelet count at this moment was 82,000 per microliter. This question is to Dr. Madhuri Jayawardena, consultant obstetrician and gynecologist. So I have 3 questions. What are the maternal and fetal complications associated with placenta previa, and how do you minimize these complications?
Prematurity, and that's the main worry when it comes to the fetus, because if they start bleeding heavy, life threatening, then we need to bail out by doing a cesarean section to reduce the bleeding. So the baby will end up in neonatal care facilities. How do you minimize these complications? We can do and we need to do, because this is one thing that we have already diagnosed, placenta previa, and there is a placenta previa care bundle that we can provide, that is to provide the bare minimum facilities to optimize the maternal care. So I'm not going to go through the entire placenta previa care bundle. So basically the principles govern the placenta previa care bundle is that all basic obstetric units with facilities should be able to provide care, which includes intensive care unit, the multidisciplinary team, and then the whole management depends on pre-planning and be proactive for this one. One thing is to plan the timing of delivery, because we don't want, especially this patient who has placenta previa anyway, with or without ITP, can bleed a lot. And on top of ITP, there will be a devastating effect. And then the obstetrician cannot manage this patient alone. And then we need to get the help of the transfusion specialist and the hematologist, and of course the anesthetist. Or if we have intensivist, we need to get them down. And then the timing is very important. If someone is placenta previa, comes with active bleeding in the middle of the night, then it's obviously going to get the matters worse. So we are plan should be to deliver by 37 weeks. We usually, if pure ITP, no placenta previa, we could wait and we don't need to do a cesarean section. Up to 40 weeks we can go. But here, it's better to get the baby out by 37 weeks so that she is having less chance of going into emergency labor and bleeding. So that's one thing. And then we need to be aware that such a patient exists. And then ideally, we should bring them down at least by 36 weeks to the hospital and then assess her. We have adequate time to optimize her platelet counts and all, so that you can give IVIG or methylprednisolone, and we can liaise with the hematologist and make her optimize and then plan the delivery. In case of emergency, then we need to manage the emergency. Depending on that, if she goes before 37 weeks, we can't deliver the baby before 37 weeks. It's unfair for the baby's point of view, but there are ways that we can even optimize when they come with active bleeding before 37 weeks, so that then we need to consider the baby's well-being as well. 37 weeks would be good for the baby as well as the mother, so that we can not go into emergency. That would be the plan. So it's pre-planning, optimizing care, and multidisciplinary.
Thank you very much, sir, for that explanation. Our plan was to review the patient in 2 weeks at hematology clinic to arrange delivery plan. But unfortunately, day prior to the hematology clinic visit date, patient presented to the ward with pervaginal bleeding. At that time, patient did not have
happens, isn't it? We plan and then comes with the emergency situation, right? So it now governs with the basic assessment, obstetric assessment first. First, we need to decide whether we are going to deliver or not, because not all placenta previa bleeds needs delivery, because they bleed and they settle. So if she's hemodynamically stable, that bleeding amount is less, we can assess her, optimize her condition, and wait a little while optimizing the fetal condition, that is to give corticosteroids for fetal lung maturity, because she is now still 34 weeks. 36 weeks of gestation anyway we are doing. So that is, if that happens that way. But if mother is compromised or the bleeding is not settling and it's ongoing, then we need to plan emergency delivery. So for that, we need to liaise with the multidisciplinary team, optimize her condition, and then we deliver. And probably, definitely we need to get the opinion from the anesthetist regarding the mode of anesthesia that they are going to give. And then the most senior person should attend to this delivery, definitely, because we anticipate uh, major postpartum hemorrhage. And there are ways that obstetrically we do certain things to minimize bleeding, how to deliver the baby, how to plan depending on the level of the placental things. So we, even at the emergent situation, if we have the scanning facility, we just do a scan and pre-plan what kind of skin incision, what kind of uterine incision we do, and then we liaise with the team.
Thank you, sir. This question goes to Dr. Ramani Pallamulla, consultant anesthetist. Madam, how to decide on mode of anesthesia depending on the platelet count? And what is the preferred mode of anesthesia for this patient?
Okay, now this patient, the problem is not providing anesthesia. We have to make sure that she has adequate platelet count, and we should prepare the blood. Now there is a high risk of postpartum hemorrhage. During surgery also she can bleed. So therefore adequate amount of blood should be kept ready, at least 3 to 4 units of blood and platelets, because the platelet count is low. Actually, this platelet count, say if this patient didn't have a placenta previa and only the problem was low platelet count, then we wouldn't have bothered much actually. 50, above 50 is quite okay. But here there is an additional problem, placenta previa, and so both things, both problems together can cause severe bleeding. So that is our worry here. Now again, depending on the situation, whether it's an elective cesarean section or the emergency. Now in the emergency situation, then the platelet count is 53,000. So I think quickly we may be able to get some platelets ready, call the blood bank and keep platelets ready, and blood also ready. And the mode of anesthesia, now it should be either general anesthesia or regional anesthesia. So
The mode of delivery, actually in an ITP patient in general, depends on the obstetric indication only. So that's an important thing. ITP per se is not an indication for cesarean section, right? And important other facts are you have to avoid instrumental procedures like vacuum or forceps. And for a normal vaginal delivery or a LSCS under general anesthesia, 50,000 minimal would be okay. And as mentioned by the consultant anesthetist, for an epidural, it should be more than 80,000. But spinal, I think, can be safely managed with more than 50,000 count. And you have to avoid NSAIDs and IM injections if there isn't a safe platelet count. And if the platelet count is less than 50,000 at the time of delivery, you can preserve platelets and go ahead with the delivery. Then there is active management of third stage of labor, preferably. And regarding on the thrombosis risk assessment, thromboprophylaxis is offered to the patient.
Thank you very much, madam. Moving back to our patient, the mode of delivery was decided by the obstetric indication, which was placenta previa. Patient proceeded with the lower segment cesarean section. It was an emergency section under general anesthesia with platelet count of 53. Due to excessive bleeding, platelets were transfused intraoperatively and IV tranexamic acid was given. This section is also for our consultant hematologist. Madam, what are the concerns on management of neonate? And if platelet count was low, how would you give vitamin K?
Yes, so after the delivery, we have to take there's a risk of thrombocytopenia in the neonate. So after delivery, we have to take the cord blood sample for the initial platelet count. We have to avoid heel prick samples because it gives falsely low values and false impression of thrombocytopenia. So if the platelet count is safe initially, you can go ahead with the IM vitamin K injection. And if the initial count is normal, you don't have to repeat daily. Maybe a repeat count on day 3 would suffice. But if the initial platelet count is low, IV vitamin K is usually being practiced, IV or oral. And we have to daily monitor the platelet count in the neonate. Especially, we are looking for a nadir count between day 2 and day 5. And if the platelet count goes beyond 20,000, we think of treating with IVIG. And even in an asymptomatic baby, if the platelet count is less than 50,000, we go for a cranial ultrasound scan.
Okay, madam. Management of our neonate. After delivery, as madam said, we sent cord blood for foot blood count. It was normal and baby was given IM vitamin K. And her baby's repeat full blood count remained normal. Her postpartum period was uncomplicated, where platelet count was remained more than 100,000 per microliter, and we tailed off the prednisolone. Proper diagnosis card was issued, and especially mother was educated, counseled regarding early booking visits during next pregnancies. These are my references. This concludes my presentation. Thank you very much. Thank you.
I'm Dr. Utpalaneti Kumara, Senior Registrar in Clinical Hematology attached to Colombo South Teaching Hospital. So, in next 30 minutes, in my presentation, I will be discussing a patient with fragmentation syndrome in pregnancy. Actually, it was a life or death situation. I'll start with the history. She was a 31-year-old mother in her second pregnancy, came at a POG of 33 weeks. And she was a known patient with pregnancy-induced hypertension, diagnosed at the gestation of 21 weeks, and she was on methyldopa and nifedipine. On admission to the ward, the complaints were abdominal pain, swelling of face and hands and ankles for 1 day duration. So my first question goes to the Dr. Madhura Jayawardena. Sir, what are the differential diagnoses for this presentation?
Okay. The most obvious first differential diagnosis is the severe preeclampsia, or one of the forms of severe preeclampsia. And if you look at this patient who had a previous pregnancy with no gestational hypertension, no preeclampsia, and someone who started to having elevated blood pressure early in the pregnancy, in the early second trimester, like in 20 weeks, you need to be very careful. It's not simple, straightforward. We know it recurs PIH, but she had a normal pregnancy. Now early onset gestational hypertension. We know they are going to tend to get worse scenarios like HELP syndrome comes more commonly in women who are not having PIH in the previous pregnancy. It's multiparous women who get HELP. So you need to get ready when you see this picture. So my first differential diagnosis is severe preeclampsia, HELP syndrome, or one of the worst conditions of that. Yeah, acute fatty liver of pregnancy is a possibility.
Okay, sir. So at this point, what further information would you require to differentiate those differential diagnoses?
The first thing, as we all started with the history, severe preeclamptic symptoms and signs needs to be checked in this patient. And then I would quickly go through the previous pregnancy and the current pregnancy record to see what the blood pressure in the first trimester. And then, of course, we need to check whether she's having proteinuria, and then the basic blood test that we do to see whether there is any organ involvement in this patient, like liver functions, renal functions, full blood count, and urine albumin.
Okay, sir. So this is her history. She had frothy urine with a good urine output, but no sinister features such as vomiting, headache, visual disturbances or convulsions, and no pervaginal bleeding, no fever, and luckily the fetal movements were present. In the first pregnancy, it has ended up in emergency seizure due to intrauterine growth restriction and fetal distress at gestation of 33 weeks. However, no pregnancy-induced hypertension in first pregnancy, and the postpartum period was uneventful. In the general examination, she was pale and there was a tinge of icterus, and significantly the facial puffiness and the edema of the hands and ankles were there. In the cardiovascular system examination, she was tachycardic with the elevated blood pressure of 170 by 110 millimeter mercury. Precordial examination and the respiratory system examination were unremarkable. And in the abdomen, there was significant epigastric tenderness, however, no right hypochondriac tenderness, and the baby was at Kepelik presentation, and fetal heart sounds were heard. It was 132 beats per minute. And the central nervous system examination was normal with normal GCS, normal reflexes without clonus. So I think you have already answered the question. Do you want any bedside investigation at this point?
Urine albumin.
Yeah. So in the urine ward test revealed proteinuria of 2+ with normal capillary blood sugar level. And the transabdominal scan revealed baby is at Kepelik presentation and no evidence of placental abruption, and the estimated fetal weight was 1.4 kilos. And luckily the CTG was reactive at this stage. So again, with this clinical picture and bedside investigation findings, what is the most likely clinical diagnosis, sir?
Still, it's severe preeclampsia, considering her very high blood pressure and the presence of proteinuria.
Okay, sir. So again, the question goes to you, sir. How to categorize preeclampsia depending on its severity, and whether the management differs according to the severity of preeclampsia?
Yes, actually, we need to categorize the gestational hypertension into various degrees. Depending on the degree, we decide on the timing of delivery mainly. So we know there is gestational hypertension, and then the next step would be to have preeclampsia. Preeclampsia is when the gestational hypertension goes beyond the hypertensive level and start to hit the endothelium. That's where we get the endothelial damage causing protein secreted in the in urine, and then when it goes beyond the endothelial, just the endothelial damage, and when the organs get involved, then it is severe preeclampsia. So gestational hypertension, preeclampsia, severe preeclampsia, and then we have varying degrees of variants of severe preeclampsia like HELP syndrome, where depending on low platelets, elevated liver functions, hemolysis, we call it HELP. In American guidelines, they also discuss HELP syndrome and L syndrome, and then there are even acute fatty liver can be part of this picture, even though there may be a different pathophysiology altogether to this scenario. And this, in particular, in this patient, if you look at her examination findings, she has a tinge of jaundice in her eyes. So jaundice, sudden onset in pregnancy, is very significant.
Okay, sir. So, what would be the initial management of this pregnant mother, sir?
When you get a patient like this who is now having evidence of severe preeclampsia, we need to assess the patient in total. So we want the blood investigations in our hand. We need to obviously optimize the mother as well as the fetus. Here the fetus shows signs of fetal growth restriction. That is also part of severe disease condition. So my objective is to optimize the mother. So initially we don't have much information, and we want more information on what kind of organ involvement and what are the other investigations, and then the fetal optimization. And think this patient needs delivery, so therefore we need to think of corticosteroids to the fetus as well.
Okay, sir. So, I think you have already mentioned this as well. What other first-line laboratory investigations would you request at this point? So, I think full blood count, SDLTs, and creatinine. So, these are the results of those investigations. In the full blood count, it revealed severe bicytopenia. Hemoglobin was 7.1 grams per deciliter, and the platelet count was 30,000 per microliter. And the transaminases were elevated with ALT 171 and AST of 159. Serum creatinine was normal. So at this point, any other investigation you would request with the result of initial investigations, including full blood count, sir?
Yeah. Here, if you look at the full blood count, there is evidence of low hemoglobin as well as low platelets. So we want to know whether there is any hemolysis in this patient. So either blood picture or LDH level will be helpful to us.
Okay, sir. So this is the similar picture to her blood picture. So I think you can all appreciate some sinister things here. So my first question to the consultant hematologist, Dr. Damika Gunawardena, what are the salient features in this blood picture?
Yes, so in a patient who has bicytopenia, severe anemia and thrombocytopenia, this blood picture is like a magic diagnosis, right? So you can see these red cell fragments here, few spherocytes, and you can also appreciate the severe thrombocytopenia on this blood picture. So putting everything together, it is very obvious that there are hypochromatic cells as well. So it is a microangiopathic hemolytic anemia.
Okay, madam, with these blood picture findings, what would be the most probable hematological diagnosis?
Yeah, so the diagnosis would be thrombotic microangiopathy or microangiopathic hemolytic anemia. So,
so at this stage, what further investigations will you perform, madam?
Yeah, so one thing is we need to know whether she's hemolyzing. So you have a set of investigations to establish hemolysis, which is your reticulocyte count, bilirubin, the indirect fraction will be elevated and the LDH will be high. So please don't forget to order tests to establish hemolysis. These are very simple: retic count, liver function tests, and an LDH. They are all done in the state sector, right? So on the other hand, it is vital to perform a coagulation profile, which is APTT, PT, and TT. Remember that we are running short of APTT reagents now, so I don't know how we are going to do this in the future. So in which case your clinical diagnosis, assessment, and blood picture and stuff like that are going to be very important. So those are the two main things that I would want to see.
Okay, madam. So these are the results of those investigations. In the coagulation profile, the prothrombin time was elevated with 19.4 seconds, and the APTT also with 45.4 seconds, and the 3T and Klaus fibrinogens were normal. And the hemolytic screening was positive with high reticulocyte count of 8.5% with indirect hyperbilirubinemia and elevated LDH level. Direct antiglobulin test was negative. So, madam, with these investigations and clinical presentation, what is the final diagnosis?
Again, it comes to a diagnosis of thrombotic microangiopathies. Now, this is characterized by a hemolytic anemia, low platelets, and organ damage due to formation of microthrombi. So it is a fairly life-threatening condition, so it is very important to urgently diagnose this and take action as soon as possible. So when you look at this group of disorders, if you put the next slide, please. Yeah. So actually there are 4 that comes into my mind when I talk about microangiopathies in pregnancy. So each one has its salient features. So it's kind of rather easy to diagnose, I think. So preeclampsia, like our patient, would have a very prominent elevated blood picture. She would have other features as well, but in different low degrees, right? So TTP, on the other hand, will have a severe thrombocytopenia with prominent neurological signs, seizures, focal neurological signs, sensory motor problems. So, so then that would point you to a TTP. And the management is totally different to eclampsia. You would want a plasma exchange in case of TTP. So that's why you need to diagnose them accurately. On the other hand, atypical HU is not very common during pregnancy. Postpartum it's commoner. That will have a renal problem as a predominant feature with other features, in not very significant ways. And acute fatty liver of pregnancy, just like Madhura mentioned, pregnancy, a patient coming with severe icterus, hypoglycemic, with markedly deranged liver functions and coagulopathy would point you to acute fatty liver of pregnancy. Remember, all these things are life-threatening and urgent intervention is necessary. So this chart will provide you with a guide as to how to direct further management. Yeah, so yeah, I've already spoken about this. Yeah, so it is HELP syndrome.
Okay, madam. So, with the diagnosis of HELP syndrome, what is the hematological management and how do you optimize HELP plan to proceed with delivery?
Yeah, I think by now with the features, we've sort of more or less come to a diagnosis of HELP syndrome. So, there is a coagulopathy. Remember that in TTP, HUS, there won't be deranged coagulation. So it's helpful. Here there is a coagulopathy which needs correction prior to delivery, right? So you can give FFP 15 ml per kg to correct your INR and APTT ratio to below 1.5. May not be able to correct it, but you may try correcting it. And the platelet count target, I think we had discussed in the previous case. So spinal, epidural, the cutoff points were discussed, and normal vaginal delivery. Could you say she had a count of 50, right? So she's ready for delivery. And because it's a hemolytic anemia, you would have to request post-surgery. These are minor things that you may forget. And of course, the blood transfusion for
if someone is diagnosed with HELP syndrome, which is part of form of, I think it's a form of severe preeclampsia. Look at the severe preeclampsia and HELP syndrome goes hand in hand together, even though we think there are minor variations compared to severe preeclampsia and HELP syndrome. So good thing about HELP syndrome is once we deliver the baby or terminate the pregnancy, they tend to they tend to get better. So if you diagnose HELP syndrome, that's the time to deliver the baby. Obviously, we can buy time. We need to optimize the mother's condition. That's why the multidisciplinary team needs their inputs. And here we need to, as I mentioned, consider the fetal well-being. We give steroids because she's still 33 weeks. 33 weeks is a good time to deliver from the baby's point of view. Our neonatal care is such. The major neonatal complications at 33 weeks is similar to 37 weeks, even though they might end up in PBU and needing care, but this patient is having a little bit of fetal growth restriction as well. And for what we do for this patient, well, she had a previous cesarean section for fetal growth restriction. We need to expedite the delivery, 33 weeks. If she is not in labor, the cervix is unfavorable, she will end up in a repeat cesarean section. I think that's the safest mode for this patient. For that, we have to liaise with the anesthetist, and we need to arrange an intensive care bed or ICU bed, or at least a HDU bed after delivery, because the postpartum care is as equally important for this patient, because the postpartum complications, we know they can happen. So we need to be careful, especially with the fluid that we give to her. And perhaps because of a severe high blood pressure, we need to consider continuing max sulfate at least for 24 hours. For those things, we need to liaise with the anesthetist or intensivist.
Thank you, sir.
Now, if she was a 28-week with hemodynamic stability after antihypertensives and all, and there is no, the fetal growth is okay, how long can you drag on the pregnancy to save the baby?
If we diagnose HELP syndrome, we know HELP syndrome, there is, even for preeclampsia, there is no treatment. There is no reversing the disease process. Once the disease process sets in, it keeps going. We can only control the blood pressure. So that's why we need to properly diagnose what is happening in the patient. Let's say she's having purely severe preeclampsia with pure severe hypertension. We know hypertension can kill the mother with intracranial hemorrhage. So if the other organs are not involved yet, by controlling the blood pressure, we can drag on, considering the fetus. Even at 24, 25 weeks, 1 day matters to the baby, not at 33 weeks. So there are kind of cut-off period of gestation values that we use with our hospital perinatal statistics and all, what kind of survival this baby is going to have. There are two ways to Damika's question. I think if it is very early, like let's say 22 weeks, someone is having HELP syndrome, yes, we know no point dragging the pregnancy further. Just we are going to jeopardize the mother's life. That fetus has very little chance, because we know we can't drag a long time. 22 weeks to reach survival, at least we need to keep the at least for 3 weeks. So we said, okay, we are going to deliver by doing hysterectomy. It's when it comes to the middle part where baby can go both ways, like 28. So that time we always, within our heart, we tend to push a little log, at least 1 day till the steroids get going. At least 48 hours we can push, considering the fetal well-being, but we need to be very careful. It's mother first, second the baby. If we can do best for the both, it's good, but first thing, the mother. So we decide on those facts. I think that answers the question. HELP syndrome? HELP syndrome? It's very rarely we drag, because we know it's not going to reverse. What do you think, madam? You agree with me? Yes, it's more or less, it's a very dangerous red flag when it comes to HELP.
Help feature, I mean, liver enzymes elevated, maybe just slight elevation, 7 to 9. And the platelet sometimes we wait few days and see, no? I have seen, I mean, in the ICU, with careful observation, monitoring, management of blood pressure and all that.
I guess
But normally you tend to deliver.
it is when it comes to the middle area where there is some hope to the baby, we can push at least the steroids starts working for the baby, right? 48 hours maximum. That is also with very careful analysis.
Here, the liver functions are deranged, and you try to be too smart, and the patient has some problem, you have no way of answering.
So the final two questions to Dr. Ramani Pallimulla, the consultant anesthetist. Madam, what are the challenges you encounter when giving anesthesia to this patient for cesarean section? Because there are several problems including hypertension, coagulopathy and thrombocytopenia. And what would be the preferred mode of anesthesia?
Again, as I explained earlier, preferred mode of anesthesia, it depends on the situation. Now, here, of course, we have to stabilize the mother, as Madhura said. Mother's life is the most important, so we must save the mother's life. Now, this patient is severely edematous also, isn't it? Yeah. So here we anticipate more airway problems with general anesthesia. And on the other hand, now she has severe coagulation derangement. So obviously, preoperatively, we have to correct with the FFP. The required factors should be replaced with the platelet count. What is the latest platelet count?
35,000.
35, obviously needs platelet transfusion. And get the levels to safer. So as Dr. Damika explained, APPT-INR, or if we have ROTEM, we do ROTEM, and correct the coagulation problem. And in this particular case, now it is really a challenging situation. Now, one hand, one side, we have gained weight with severe edema. So both regional and GA both can be difficult because we must be having severe sacral edema as well. Epidural is out here. So the options are GA or spinal anesthesia. Now here, in addition to the platelet problem, now severe coagulation derangement also, and I mean you may correct it by giving blood products, but again it is a ongoing process. Again it can get deranged. So we need a platelet count at least 6 hours before cesarean. Recent platelet count rather than yesterday's platelet count. So we have to go by that and correct. And here, as I can see, if I am a consultant anesthetist, actually can again assess the risks and benefits and see the patient and assess the airway, and then take the decision whether to put GA or regional. Still, a consultant anesthetist can give a final anesthetic to this patient after correction. So it is the anesthetist or the consultant's choice here, right? Still I would, and even I know experienced obstetric anesthetists prefer to give single shot, careful, fine, right? And to avoid problems of, but on the other hand, consultant should be able to motivate the patient. But it is the problem now. We have to think of not only the critical care. It is a hypertensive patient. Blood pressure is very high. So at the time of intubation, the pressure can shoot up further, and that may be the time for cerebral hemorrhage, the time of incubation. So that has to be done very carefully. You know, there is adrenergic response to laryngoscopy, where the heart rate goes up, blood pressure shoots up. That has to be minimized using. So it is a special type of induction of general anesthesia. It's called modified rapid induction. If the anesthetist is not very aware, might use the normal traditional induction that can cause cerebral hemorrhage. So it has to be done very carefully. It depends on that patient's clinical situation at that point. And change the decision, I would of course prefer fine always.
So I think you would like to know what happened to our patient finally. So patient's blood pressure was not controlled even with multiple antihypertensives, and that the CTG also showed some deceleration. So at this point, it was critical to make a decision whether to continue the pregnancy or terminate. So we have to save both mothers and baby's life if possible. So at this point, we got the NDT approach by consultant hematologist, anesthetist, as well as the obstetrician. So finally, it was decided to terminate the pregnancy. And after correcting the anemia, coagulopathy, and thrombocytopenia, patient actually underwent emergency seizure under general anesthesia. And the mother was transferred to the ICU and the baby admitted to the PDU. And luckily, the baby did not require respiratory support. And within around 48 hours of delivery, the platelet count started to recover and patient became normotensive and she was transferred to the ward. So after around 2 weeks of delivery, once the baby was transferred to the ward, we were able to discharge both the mother and the baby. So due to the proper timely management, we were able to save both mother and the baby at this case, and it was a happy ending. So with that, I will end my presentation as well as it is the end of the symposium on DD. Thank you very much.
Thank you. We are on schedule. We have some minutes for questions. There are some questions from the virtual forum. There is a question regarding actual case. If I am to summarize, this is a primary mother with in T1 with a macrothrombocytopenia with bone marrow showing myelofibrosis. Ultrasound, no hepatosplenomegaly, and the last count is 32,000. So the question is there a cutoff limit to be maintained, and the role of prednisolone in the pregnancy? I think this was dealt with in the discussion, but if there can be some elaboration on this specific patient.
A bit of a tough question. So platelet functional disorders, actually there are only 4 choices. We can try tranexamic acid, desmopressin, platelet transfusions, or we could, in a very kind of dire emergency, we could give factor 7. So this patient, I'm just wondering whether she has Bernard's only. Is that the one which gives large
Probably
platelets
it sounds
with
like myelofibrosis in the bone marrow.
So it's really tough managing this patient because maintaining the hemoglobin could be an issue. And so I would say that tranexamic acid and platelet transfusions should help. I don't know, because a platelet count of 32 with a platelet functional disorder could bleed, unlike ITP. So it's a very difficult situation. I suppose anybody has to add.
Preeclampsia with HELP syndrome, I think the platelet function is also affected. Is one of the conditions other than the count. Drop in the numbers.
So there are many acquired platelet functional disorders. So this is an inherited one. So which is difficult to manage. So I don't know whether I gave you the answer to that, but tough situation, I would suggest tranexamic acid. DDAVP has a place, I think, in Bernard-Zollier, and platelet transfusions. Place of steroids, I don't know whether there is any documented option on that.
It has been shown that other than for the fetal lung maturity, for the mother, there is the platelet count may improve. The studies have shown the count may improve But there is no difference in outcome.
That's the
seems.
thing. These
Yeah.
are functional disorders,
Yeah.
so I don't know how much steroids are going to help.
Not recommended for the mother's point of view, but for the fetal thing, there is.
I think the question may have stemmed from the point where she has responded in 2017 to a short course of prednisolone, where the count may have gone up. But you wouldn't want to specify a safe limit for this
No,
patient.
I don't think. Do you think, Chandima? No.
The next question. Sorry.
Yeah, well, I think, yeah, checking the pathophysiology and how the drug acts, I also kind of can't explain how, if anybody else can explain, but it is kind of known as a definitely effective agent, which is sort of which will stop bleeding. So I don't know, honestly, the answer to that question.
Produce some small clot, and that clot fibrinosis is what we are trying to prevent. I mean, whatever we have, we are trying to stop it from breaking down. So that is not the treatment. Yeah,
Action,
it is
very
a very non-specific
non-specific,
thing.
but
That is not the treatment, but the answer to your question is why tranexamic acid, when the platelet function defects are the main underlying pathophysiology.
The next question is, what is the place of L thromboplaque in severe ITP, as in the case scenario? If I am to reword it, what is the second line options if prednisolone doesn't work for this patient?
Yeah, actually there are limited second line options. L thrombopac, there are case reports which have been safely used in pregnancies, but manufacturer doesn't recommend L thrombopac in pregnancy. So actually the options we have in pregnancy are prednisolone and IVIG at the moment, or combination.
The next question from the virtual forum is, please explain the difference of thrombin time and Klaus fibrinogen, how to interpret results. I think maybe a non-hematological point of view, do I need to do both these tests for my patient, or if there can be a simple answer to that?
actually, it's you don't have to do both. Thrombin time is basically a simple test to check the overall availability of thrombin and fibrinogen and the functionality of fibrinogen. So it will check both, whereas Klaus assay will only check how functionally good your fibrinogen is. So I would say in a bleeding disorder, you would ask for fibrinogenemia. Am I right, Chandra?
Yes. Yeah, so if the thrombin time is prolonged, we can go for fibrinogen estimation, the antigen estimation and the functional assay. Right? Thrombin time has to be prolonged.
So it can be sequential rather than done at the same. Okay, so that in the absence of further questions from the audience, it concludes our second symposium. We'll break the forum for tea and gather back in about. Is there a question? Yes. There is one more question.
In that patient with thrombocytopenia, you discussed the pre-delivery level estimation was 50,000. Just after delivery, it rose to 100,000. Now, what is your observation on that?
Intraoperative
In the previous case.
Yeah, transfused.
If 50,000, just after delivery postpartum, it rose to 100,000. So what is the observation on that? So does that mean that it is a therapeutic, it has a therapeutic effect also? The delivery has a therapeutic effect. Yes, so that's a good observation, that not to delay delivery because the delivery itself is a therapeutic effect on the condition. Thank you.
Now it's time for the third symposium. This is a symposium on thrombosis. The speakers, first will be Dr. Oshani Kakulavala, speaking on the topic dealing with valves in pregnancy, getting a good balance. Second speaker would be Dr. S. Mayurathi. She'll be talking about when clotting gets wild. To end the all-female streak in presenters, the last speaker would be Dr. S. Sayanthan. His topic would be silent killer, antiphospholipid syndrome in pregnancy. So this session is also timed for 1.5 hours.
Good afternoon. I'm Dr. Oshani Kakulavala, Senior Registrar in Clinical Hematology from National Hospital of Sri Lanka. My topic is dealing with valves in pregnancy, getting a good balance. My patient is Mrs. A, 22 years old, P1C node, a diagnosed patient with rheumatic valvular heart disease at the age of 14 years and underwent mitral valve replacement with St. Jude mechanical valve and started on warfarin. Target INR maintained between 2.5 to 3.5 with a dose of warfarin 7 milligrams. My first question goes to the consultant cardiologist. Sir, what is the best choice of prosthetic valve for young women with fertility issues, whether it is mechanical or bioprosthetic?
I think one of the most important question that we have to raise. First of all, if I go a little bit further, there are 3 options that we can think about. If you find a young female with some valvular disease, the first is, of course, even though you are not addressing, whether we can leave that valve intact without putting any mechanical sort of valve, and whether that patient can go ahead with the pregnancy with the native valve. That, of course, unfortunately, in our setting, we don't have such a discussion, which we need multidisciplinary team to decide whether that patient can go ahead or can go through the pregnancy without having major cardiac events. So that we have to do quite a lot of investigations, cardiopulmonary investigation, to see the patient's fitness. That, of course, can be done, but unfortunately in our setting, we are not doing that. And then it comes to your question, which valve is good? Prosthetic valve, the bioprosthetic valve, or a mechanical prosthetic valve. It again all depend on the patient factors, the mother, the fetus, and the other factors, especially related to the mother. Now, if you take from the fetus point of view, the best valve is bioprosthetic valve, because there we can manage only with aspirin without having warfarin. And the if you take the registries, because no randomized control trials available in this field, unfortunately, the registries, if you go for bioprosthetic valve, the patient, the mother can have go through a event-free pregnancy for about 79%. But you have to keep in mind, again, 21% risk of getting complication during the pregnancy. So that's quite high. It's 21% means, in our terms, medical terms, very high risk. And if you consider the same thing for mechanical valve, the chance of event-free pregnancy and having a live birth is somewhere around 55%, 55 to 58%. So you can see 50% chance of getting complicated during the pregnancy. So if at all, for your question, what is best? The bioprosthetic valve is best. But there are some drawbacks in bioprosthetic valves. The first thing, bioprosthetic valve. Now, if the patient, now in our setup, sometimes we are not doing the surgery at proper time, and then we are getting delayed until the patient getting complications of the valve problem, say especially atrial fibrillation. So if you get a patient with atrial fibrillation, it's no matter whether you have a bioprosthetic valve or mechanical prosthetic valve, you have to be on warfarin. So the value of adding bioprosthetic valve for that type of patient is no value. So that timely surgery is again important to assess, and which patient needs which one, and which time that we need to. Unfortunately, our setting, you all aware how many years that a patient has to wait in the list for a valve surgery. And then again, other significant thing that I want to tell you, there are other things. Say, what we usually see in Sri Lanka, mitral valve problems, mitral stenosis, which is rheumatic, or otherwise mitral valve prolapse, causing mitral regurgitation and so on. So if we now, if we can detect most of these things early, probably mitral valve repair is a very good option, but it's a very need a very talented specialized team, which we are lacking at the moment in our country. A lot of surgeons are doing, but in other countries there are cardiothoracic surgeons who are only dedicated for repairs. So that if you have repairs, a dedicated team of repairing valves, the success rate is high. In our setup, what is happening, usually we are starting with the valve repair, but ultimately end up with valve replacement. Is because of our facilities, and since we don't have dedicated, very specialized, final specialized team for that type of thing. So again, the as I talked about, I couldn't tell you the now event rate. If you are going with the native valve with the problem, still the chances of facing a problem somewhere around 21%. The event-free rate is somewhere around 78-79%. So it's almost same as bioprosthetic valve. So in summary, for your question, for any patient with a valve problem, before they are becoming pregnant or even before they are getting married, we have to have a discussion with the multidisciplinary team, which patient needs surgery and which patient doesn't need surgery, and can postpone couple of years, and advise them to get the pregnancy forward and delay the valve surgery. That is one option, and of course cheapest option. And the second thing, for a suitable patient, bioprosthetic, but economic point.
And next two questions are also to you, sir. Is there a place for aspirin in preventing valve thrombosis? And how would you decide a target INR for mechanical prosthesis?
First question is with regard to aspirin. Usually aspirin is antiplatelet, not antithrombotic, and doesn't have in prevention of thrombosis in valve setting. But I have seen the patients where the patients are on warfarin, very high doses, 9 milligram, 10 milligram, sometimes even 11 and 12 milligram. And those patients, hematologists are adding aspirin on top of that. I'm not sure why it's really done, but some patients with the valve patients with high dose of warfarin, when they are not reaching the INR, I have seen some hematologists putting aspirin on top of warfarin. I'm actually not 100% sure why it is. Dr. Anoma will explain sometime. But otherwise, usually for valve patients, aspirin, there is no additional protection. The worst thing, of course, increases the bleeding complication significantly. So especially ICH and so on, which could be devastating. So I don't think that aspirin has a place. And your second question, INR. The INR, of course, now, as you know, thrombogenicity, now couple of things you have to consider. First thing, patient factor. Second thing is the valve, the type of valve, and the location of the valve is again important. So you might have already aware that the valve at mitral position or valve at tricuspid position is in higher risk of getting thrombosis than the aortic valve and the pulmonary valve. It's because of shear stress, because when you have the flow across the aortic valve and pulmonary valve, the flow velocity is much higher than the mitral valve and the tricuspid valve. So because of that, the chances of that the famous triad, when the flow velocity is high or stagnation is high, the thrombosis is high. So with that, the pulmonary and aortic valve position, the chances of thrombosis less, and you can be little bit relaxed than the mitral and tricuspid. That is one thing. And then the valve type, the newer generation valve, which we usually see if you are seeing in notes, St. Jude's, Onyx, and Carbomedics, bileaflet type of valve, more physiological and more resistant to thrombosis. So those valves are better. But if you get, say, decades ago, you might have seen the Starr-Edwards valve, that is cage and ball valve, which is very thrombogenic. And because of the same thing, I just wanted to tell you, now when you are writing a diagnosis card or whatever the notes, rather than the valve position, the type of the valve also important to go in the notes, because that gives additional value, and the size as well. So those are important points. Then again, atrial fibrillation, and if the patient has severe LV dysfunction, those are additionally high risk patient factors, or any other, if the patient is having any other like antiphospholipid or something like that, any thrombogenic condition, those patients are high risk. But always not the figures, not the guidelines, what you have to think about the patient. So at the same time, if the patient is having significant bleeding problem or any other very high bleeding risk, you have to compromise and come down. The chart is there, which is recommendation, but you may need to go a little bit further, higher, or a little bit lower down, depending on the patient's requirement and to consider the patient's safety. So this is, you can get it from the guidelines, it's very easy. But for you to decide what is the ideal INR range, you have to see the patient, take the history, go into the past history, see the valves and so on, and then you have to decide which is the best range. Even within the range, sometimes even you see that we say for mitral valve, usually 2.5 to 3.5 is good enough, and we are not seeing any complication with that range. But some patient we are trying to manage in the range of 2.5, close to the lower range. Some patients we are managing at the range of 3.5. That is individualized decision for each and every patient. Ideally, you should do that way rather than stick strictly following the guidelines, because if you follow in the guidelines strictly without seeing the patient, you will end up with the complication.
Thank you, sir. Yes, Dr.
we as hematologists also don't recommend to add aspirin on top of warfarin in therapeutic dose without any real indication because it adds to risk of bleeding. I am not aware why some hematologists have added it. There may be some another indication on top of valvular. I don't know really.
Even in pregnancy, when the patient is on warfarin, adding aspirin increasing the risk of the issue. Now, there are indications for triple therapy, that is dual antiplatelet and warfarin, and dual antiplatelet plus novel anticoagulants. Those things are there, but it's not for long periods. Basically, we stick to 3 months maximally with very carefully, because for those patients, problem is if that patient develop ICH, that's the end of the story, because it's devastating ICH and the patient will not recover. Recover means recover fully to normal day-to-day life. So it's actually you are just like killing the patient with triple or double anticoagulants if the patient develop ICH. So you should be very careful.
Thank you, sir. Thank you, madam. Our patient presented with POA of 5 weeks duration, and ultrasound scan confirmed that there is a live fetus. 2D echo revealed mitral prosthesis, mitral valve thickening, and dilated left ventricle. So she presented with a pregnancy. We all know pregnancy is a prothrombotic state because of relative increase in fibrinogen, plasminogen activator inhibitors, and clotting factors, including 1 millibrand factor, and increase in platelet adhesion molecules. And there is concomitant decrease in protein C activity. So, strict control of anticoagulation is necessary to reduce the thrombotic complications. But it is challenging due to increased renal clearance and volume distribution associated with pregnancy. So, we have 3 options for anticoagulation: vitamin K antagonist, low molecular weight heparin, and unfractionated heparin. There are limited studies done on this cohort of patients, but according to a UK study, they have demonstrated that 9% of patients develop thrombotic complications, develop maternal mortality related to thrombotic complications, and out of this 9%, lowest number of valve thrombosis develop with vitamin K antagonists, that is 0 to 4%. And highest number of thrombotic complications develop with unfractionated heparin, that is 9 to 33%. 4.4 to 8.7% of patients develop valve thrombosis even with low molecular weight heparin and proper anti-10A monitoring. So, according to these studies, the best anticoagulation for mechanical prosthesis is vitamin K antagonist. But is it safe for the fetus? So, this question goes to Dr. Prabodhana Ranavira. So, what are the obstetric and fetal complications related to warfarin?
Right. Thank you. Right. Number one is like there are chances of miscarriages because there can be placental separation early and then can have a bleed and the pregnancy can be ending. And also there's nasal hypoplasia, limb deformities and things like with warfarin. But all these are increased when the warfarin level is more than 5 milligrams. As Sampath said, right, so when somebody is pregnant or when a woman is there with a prosthetic valve, if you ask from the cardiac, now even if the statistics we say that, so there's a 50% chance of having a problem during pregnancy. So number one is if you can avoid the pregnancy, better to avoid the pregnancy, because as you said, and then when it's through the pregnancy, then warfarin is the best choice of drug. And then we have a chance of having problems with fetus. But sometimes having a little bit of a nasal hypoplasia is better than the mother not being there, right? And then comes, even with anti-10A monitoring, which happens in Sri Lanka episodically. So some days we have factor 10A monitoring, some days we don't have monitoring. So if they don't have, then we have only one choice. So then it's all about managing a patient, as Sampan said, it's not guideline per se. It's not the because as he said, if somebody is on warfarin 9 and then he have a placenta previa or had a bleed earlier, then we have to come down on the anticoagulation because rather than something which may happen, which is the thrombosis, she might bleed to death before even going having a prosthetic thrombosis. So these are the issues that we have to think, and the bivalve or anything, it's can thrombose in two different direction, either in the closed status or open status. It's like a door. Hinge can be closed, and then if you have a thrombosis, that's usually the end of the patient because it's like severe mitral stenosis, and by the time we take to the theater and try to do something, it can be, we may not have time. But if it is stop at the open stage, it's a severe mitral regurgitation, we may have little time to go and do anticoagulation or a repeat surgery. So these are the problems that we have to, but to answer, fetopathy are there. They are with less vitamin K doses, sorry, what you call warfarin doses, the chances are less than 3%. So in the above 5 milligrams, the chances are slightly higher.
Question is also to you, sir. What is the ideal time to start our management? So our patient presented at 5 weeks of POA. Is that the correct time to start our management? Or do we have to start from the pre-pregnancy?
So I think I answered earlier, no? Yeah, right. So, yeah. So basically, as I told, the best would be having a preconceptional counseling, right? So whether to see whether she embarking in surgery is safe, as it's not just having the valve, but whether she has a higher risk of having a problem, like whether if she's having atrial fibrillation and she's on higher dose of warfarin, and her compliance is poor, and she's obese, and there are other complications, whether she has another child before that, all we have to take into consideration. So an ideal would be now ideal patient going through the pregnancy would be, as he said, if possible, bioprosthetic valve or with a native valve with problems, but we can manage it. Second, if she has a mechanical valve, have to have the lowest possible dose of 5 milligram, what do you call the warfarin. So we have to see whether, so basically warfarin is a vitamin K, anticoagulant, so which works on vitamin K. So if we reduce the intake of vitamin K, we can reduce the requirement of warfarin because it's anti-vitamin K. So then the patient has to be educated properly. So by with all that, unless she has a other problem with thrombosis, some other thrombotic event or risk of thrombosis, then we can come down and we can maintain our required INR by the lowest possible dose of warfarin. So it takes time. So once you achieve all that, that's the ideal time to get pregnant. Not accidents happens, like rather than a patient comes with like, okay, we didn't know now. So there the hematologists and the cardiologists has a great responsibility, because by the time they present to us, it's usually too late because they come to us when they are pregnant. So it's a requirement that if somebody is in the reproductive age group, and whether they are married or not married, discuss about their
Coagulation at 5 weeks of POA, And would that differ depending on the dose of warfarin? Now, our patient is on 7 milligrams of warfarin. How should we plan?
Yes. If the patient is on warfarin less than 5 milligram, we could continue with the same dose of warfarin throughout the pregnancy with monitoring PT-INR at least once in 2 weeks. But in our case, the patient is on warfarin 7 milligram daily. There is some risk to the fetus, therefore we can discuss with the patient, and then in the first trimester we can convert it into enoxaparin therapeutic dose 1 milligram per kg BD, and with monitoring anti-10A levels and adjusting the dose of enoxaparin according to the level, and we can continue with enoxaparin first trimester, then again we can convert into warfarin in the second and third trimester, and go on like that with monitoring with INR. These are the options although it is unfractionated heparin is an option, we don't go for that because monitoring is very difficult.
Thank you, madam.
Something to that also, because now baseline is, like as he said, unfractionated heparin. If your data, like what we say is there's a high risk of valve thrombosis, so we can't use that. Warfarin is the best drug. If we have the facilities to monitor 10A level, then yes, we can use, we can convert into low molecular weight heparin during the first trimester. But let's say if that is not available, we go by the mother's life first, then the baby's life second. So we have to then continue warfarin regardless of the dose, if they, because I have seen this happening without any monitoring, because most of the patients come to DMH, but sometimes in the peripheral obstetrics, they have changed into low molecular weight heparin, no monitoring facility available, then sent to us. But that's, I mean, we go by if there's a monitoring facility, yes. I mean, only I think Castle and us have that at the moment. I done it is. So,
it is available only at DMH, but in the other peripheries, I don't think it is not available actually. So if monitoring is necessary, they have to send the patient to one of the hospital in Colombo, and that's how we go. Otherwise, we have to continue with warfarin without thinking. We have to discuss with the patient and explain, and need to continue with warfarin regardless of the risk of.
So, anti-10A monitoring plays a significant role in managing these patients. So, madam, what are the target anti-10A levels, and what is the best time interval for anti-10A monitoring, and what is the importance of trough levels?
Actually, anti-10A is very expensive test. Therefore, we have to decide when it should be done, and we have to take samples 4 hours after the dose, morning dose, and usually at 12 o'clock we can take the sample, and it should be the test should be done as soon as possible. And this is the peak level actually. The peak level should also depend on the type of valve. The highest level in the mitral and tricuspid, as you said, because the risk is high, it's 1 to 1.2, and depending the other valves, there are ranges according to the type of valve, and we don't go for trough levels and manage with the peak levels, and that's how we do. The frequency of monitoring also, ideally it should be monitored in 2 weeks. Ideally, but we have to adjust according to the facilities available.
Thank you, ma'am. So, we stopped warfarin at 5 weeks of POA and started on subcutaneous enoxaparin 1 milligram per kg BD dose for our patient, and monitored anti-10A levels and maintained between 1 to 1.2 international units per milliliter. And we restarted warfarin at 12 weeks of POA. And now currently she is on warfarin 7 milligrams daily with a INR of 2.7. And these 3 questions are to you, madam. How should we plan this patient's delivery if it is a planned delivery? And would that be differ if it is an emergency delivery while she is on warfarin? And what is the postpartum anticoagulation management?
Then in the second trimester, as I said earlier, we convert into warfarin again, and it should be a planned delivery. And before the time of delivery, we convert again to enoxaparin with monitoring antitennial levels. And ideally, we have to stop warfarin 2 weeks prior to planned normal vaginal. Go for 1 milligram, 1.5 milligram per kg BD like high dose. Without going for that much of high doses, we have to assess the test whether it is correct for going for that high dose. This test is high. And convert warfarin to before therapeutic start of delivery. Stop and convert to manufacturing process 12 hours after the last dose of enoxaparin. Monitor the recovery with ATP, which is the ATP ratio between 2 to 3. Then it also needs to be stopped for 4 to 6 hours before the planned delivery. By the time of delivery, ATP should be within the it should be less than 1.5. Then after delivery, we have to discuss this as a MDT night for case of and we have to decide when we are going to do that. Then we have trial period, and after delivery, when the pushing is tapered, we can restart the recovery after 4 to 6 hours after delivery. We have convert to enoxaparin with warfarin. We have restarted warfarin 4 to 6 hours after.
Just to add about this mode of delivery, so we have a MDT, and then we decide whether the patient can have vaginal delivery, because when you have a cardiac disease, there are other parameters we have to take into consideration. So cardiologists and sometimes even the cardiothoracic surgeons, depending on the warfarin doses and all that, we come to a decision whether there is a need, whether she can have vaginal. We prefer vaginal delivery because cesarean section, there's increased risk of bleeding, and especially starting post operatively there'll be problems. once we decide, let's say vaginal delivery, because elective cesarean section is easy, we change it to at 36-week low molecular weight heparin, and then before 36 hours before we go to heparin, and then we stop it 4 hours before surgery, do the surgery, 4 hours later we start. So our lives makes easy if it is a cesarean, but then mother's life is at more risk because there's a high chance of bleeding. Then comes vaginal delivery. Again, now we can't, like from 36 weeks, we can't have her continuously, and we don't have Nanakkana, so we don't know when she's going to deliver, right? So we have to kind of, so what we do is we do a planned vaginal delivery. So we do a vaginal examination, see her Bishop's score or make it favorable, and we plan, okay, this day we try to put her into the labor room. So that we'll be doing that. So prior to that, they'll be changing into unfractionated heparin. And when we change to unfractionated heparin, we have to know that there's a very high risk of thrombosis. So that part we have to be conscious about it. So we can't keep on going through the labor for 12 hours, 18 hours, or no more than that, right? So 18, 20, 24 hours, we can't. So we try to keep her on unfractionated heparin for a shortest possible period of time. And we have to, and we stop it when she is in, pushing and all that, we have to stop it, right? So then the problem comes now in real life. What happens is when she is into the labor room, we stop unfractionated heparin. And then she will be, for the next 12 hours, she will be without any anticoagulation sometimes. So then there's a very high risk. So then we want the baby to be at, because the guideline is different, right? So the guideline, we can continue unfractionated heparin during labor and all that, but that's a problem because if she bleeds and all that, there's a big issue. So we stop it and then we continue that and we try to get the baby out as quickly as possible. So if the cervix is very unfavorable, and then we opt for cesarean section. So once the baby is out, then after 4 hours, we start unfractionated heparin, and then we convert it into warfarin. And then again, the mothers will be worried about breastfeeding, because if you look at the drug chart, it says it's in the breast milk, but it has been shown that there's no effect for the baby. So we have to continue and encourage breastfeeding. So these are the things. So that is why, like during that, especially this 48 hours prior and after delivery is the highest risk for thrombosis because of the change of anticoagulation from one to other. So that is the time where we have to be very vigilant and be aware. So we can't stop it. We have to be, if they have SOB and all that, we have to be very, very, act very quickly. So that is the message. And once they have a baby, we usually say that's enough. Regardless whether prosthetic valve, they can keep on having babies, but that's not fair for us, nor for the patient and for the baby also. Thanks.
Thank you, sir.
Actually, now with regards to the valve type, don't go home with in mind that the prosthetic valve is best for each and every side because it has its own problems. Now the problem, now that you might see all of our patients, the majority are on mechanical valves. The one reason being, for a country like us, probably one thing is economics, but if leave alone economics, there are some other reasons. Now, if you put a bioprosthetic valve, its lifetime is somewhere around 10 to 15 years. But if you have 2 or 3 pregnancies in between, it has come down. It usually comes down much lower. Sometimes it fails much earlier because with the shear stress in the pregnancy, valve tend to deteriorate and degenerate. And probably you may need to go for second valve replacement much earlier than otherwise. Than the other pregnant person. Now, even you think, okay, it's fine. So if you have money, you can go for a second valve. No, it's not that simple. Second valve is surgically very, very difficult. And in our setup, our surgeons are not willing to even touch and take a patient for redo surgery for valve because it's risky, complication rate is high, it's difficult, lot of time, and it's a very, very difficult task because with the adhesions of the heart and the adhesion around the perivalvular area, the fibrosis and so on. So valve adhesion is high, complication is high, difficult surgery. And you see now these patients are in somewhere around 20s, right? And their lifetime, if they need 3 or 4 valves, is extremely difficult. So their lifespan going to be definitely going to be less, because for the third time, I haven't seen in Sri Lanka a single patient has had third valve. So even for the second valve, we have to go behind surgeon and worship in them. Please do. Otherwise, this patient will die. So it's not such a simple issue in our setup, especially going for a bioprosthetic valve for pregnancy. So it's very difficult decision. So that's why multidisciplinary approach from the beginning. As he said, it's a cardiologist, cardiothoracic surgeons, and hematologists. Whoever the person who gets the patient care has to discuss this beforehand. Ideally, that has to start before putting the valve in. Okay. Thank you very much.
Thank you, sir. Good morning, good afternoon all. I am Mayurati Sachidanandan, Senior Registrar in Clinical Hematology attached to National Hospital of Sri Lanka. Let's see when clotting gets filed during pregnancy. This is a story of a woman who had thrombosis complicating her early pregnancy. When we met her, she was a 40-year-old lady and she was in her 6th pregnancy with a one living child who was 5-year-old. She was in her early pregnancy, just following 2 weeks after IVF embryo transfer. Pregnancy has been already confirmed with the serum HCG. She was referred to hematology team for further assessment of need of thromboprophylaxis. She doesn't have any other chronic illness. She was otherwise well with a BMI of 22 kg per meter squared. There was no family history of thrombosis. Then I would like to move on to the past obstetric history, which was quite complicated, and I want to highlight few facts for discussion here. She had primary subfertility for 7 years, for which the couple have been thoroughly investigated, and it was concluded possibly due to polycystic ovarian syndrome. And they have been given several options of subfertility treatment, failing which finally ended up with IVF. She has received the ovarian stimulation treatment with hormonal therapy 6 years back, where 24 eggs were retrieved and IVF done, and the embryos were cryopreserved. She has had a first embryo transfer just 1 week after egg retrieval, and the pregnancy has been confirmed with serum HCG. 2 weeks and 5 days after embryo transfer, she presented with shortness of breath, abdominal distension with evidence of respiratory compromise. On examination, she was dyspneic with evidence of desaturation, and there was tachycardia. On systemic examination, there was reduced air entry on the right lower zone of the chest with grossly distended abdomen with free fluid. Cardiovascular and the neurological examination findings were normal. At this point, I would ask obstetricians what are the possible causes that we should consider this presentation, and how should she be evaluated further?
So now, to my mind, there are two differential diagnoses. First of all, because this is 7 years ago, there is a chance of what we call hyperstimulation, OHSS. But before that, we always, if somebody is coming with SOB and pregnancy, we have to always think about the possibility of pulmonary embolism. So we have to go on that line. And because now the older days, 7 years ago, we were doing fresh embryo transfers rather than frozen ones. Now the chance of this happening, if it is OHS, the chances are high, low nowadays because of the new drugs, new protocols, long, what you call these stimulations, and then we cryopreserve embryos, then do the transfer about 3 to 4 months later, rather than this fresh cycles, and which are shown to be much more, the pregnancy-wise also better, and for the mother also. And the other problem are, you have to think about dengue and any other, one which is liver problems and things like that.
Thank you, sir. So, considering the possibility of the pulmonary embolism, what would be the preferred mode of emerging in a patient, in a lady with, especially who is in an early pregnancy, considering the maternal and fetal safety?
So we will be starting on, if we suspect pulmonary embolism, we always go for therapeutic levels, therapeutic doses of low molecular weight heparin, even before the hematologist and everybody says. So it's our duty, we start then and there with stockings and all that, then only we start investigating, and we don't wait for the duplex scans, the other either CTPA or VQ scans. We suspect, we start because there's no harm, and then we check on the later things later.
Thank you, sir. So this was again answered by Dr. Prabodhana Ranavira. So at the clinical suspicion of pulmonary embolism, how should we manage at this point? He has already answered that question. So then I will move on to next question to the consultant hematologist. If the pulmonary embolism is confirmed, then how should it be managed?
It depends on the size of embolus and how the patient is. If the patient is hemodynamically unstable, we have to go for thrombolysis, and anyway anticoagulation should be done with heparin or enoxaparin. And in a stable patient, we can go for therapeutic dose of enoxaparin. And we have to monitor the patient, and if necessary, if the patient is deteriorating, we have to again consider thrombolysis, and we have to monitor the patient while on anticoagulation.
Thank you. So at this point, I would like to ask Dr. Sampath Vidanavasam, consultant cardiologist, what would be the advantages and disadvantages of catheter-directed thrombolysis, and would you suggest catheter-directed thrombolysis over systemic thrombolysis?
Thank you again. For recap for juniors, for especially when you get a pulmonary embolism, so we have 4
what to answer, but the principles behind this, that she has had a DVT. Now there's a part we had played also, because she was sent home without anticoagulant, because now if you look at her hematocrit, it was 54%. So it's a intravascular dehydration, and she was managed the part, and then because her pro-thrombotic states continues, so she should have gone home with DVT stockings and enoxaparin until that part is over. Then she has had a DVT. We go by the provoke, it's a provoke DVT, but it's more of what we call iatrogenic rather than provoke, right? So then but by the guidelines says if you have DVT in pregnancy, provoke, then we have to continue for 3 months. So once she's off, because she's on warfarin, and we have to wait till we finish the warfarin course, because if she gets pregnant again, then warfarin effect is there. Not necessary for this patient. So, and mischaracterized, it's miscarriages are very common, 20%. 10 weeks, and majority of the time it's due to a fetal anomaly, which is, or chromosome anomaly, which is not compatible with life. So like, if we didn't know that we are pregnant, once you get your period, from the next cycle you can get pregnant theoretically, but there is a psychological impact, so we usually ask them to wait for a couple of months. So in this case, because of the warfarin, probably would have had a chance of a anomaly. No test, nothing. We just ask her to put another embryo and come.
We can consider doing DRVVT because if it is positive with the given history of DVT, although it is provoked, we have to give a slight increased dose of enoxaparin. Therefore, because of this is the last couple of embryos and the patient is 40 years of age, without taking any other risk, we can do that to give an additional dose of enoxaparin if it is positive. Other than that, I also don't recommend any other investigations.
Anyway,
one issue here now that medical point of view. Now, if we say, for example, if we identify protein CS deficiency or whatever antiphospholipid, she has to be on lifelong treatment. So that we are going to miss, and she will end up with a stroke or some other heart problem later on life. So I think now there is an indication here for us to look into that, exclude the which can thrombophilic condition, which can cause not only for this pregnancy and later on life, he will come with a devastating MI, young MI or young stroke or some other reason, some other thing which could be devastating. For only that reason,
Right. So the now it's an easy question, right? So the our assumption is like now we can't deliver babies prematurely. So after 37 weeks, we consider the fetus to be mature, and now our objective of continuing any high risk pregnancy, whether they had their previous intrauterine pregnancies, pregnancy losses, and all that, to continue the pregnancy at least till 37 weeks. So once we achieve that target, then especially if somebody has IUD and all that, where their anxiety levels are very high, from let's say if she has had lost the baby at 32 weeks, from there she will be on that high stress level until she deliver the baby. So it's considers inhumane to continue the pregnancy once we achieve the what we call the viability, or what we call the maturity point, not the viability, maturity point. So so I would consider her to be delivered between like 37 to 38 weeks. But now she has had again, then we consider the other factors. Now she has had first trimester recurrent blood cells, she has had a DVT, and again continue the pregnancy, the DVT risk and all that high. But let's say now her first pregnancy would have been a cesarean section. So in that case, this is going to be a cesarean section, and then, like for instance, let's say her first delivery was a normal delivery, and then I would try to kind of go till about 38 to 39, because then the chances of having a normal delivery is high, which has reduced risk of DVT. Now if she wants a cesarean section, then we consider that at 38 weeks. But after 37 weeks, if any doubt the baby's condition and all that, we will deliver.
A lower segment cesarean section was planned at 38 weeks of gestation. I would like to ask you, madam, how should we plan peripartum anticoagulation in her?
We have already discussed about reversal of anticoagulation prior to the delivery. Warfarin need to be converted to enoxaparin again, and we have to optimize the hemoglobin as omit aspirin because there's high risk of bleeding. And enoxaparin prophylactic dose can be stopped 12 hours prior to the surgery or delivery. And we have to keep the patient hydrated. Then postpartum, we can start enoxaparin again after 6 hours if there is no active bleeding, and need to continue for 6 weeks postpartum because of the given history of DVT in the previous pregnancy.
Thank you, madam. So she presented at 37 weeks of gestation with evidence of fetal distress, which required an emergency cesarean section. She is currently on prophylactic enoxaparin and aspirin. How should we optimize her prior to emergency cesarean section?
Because the patient is was given enoxaparin less than 12 hours, it cannot be completely reversed with protamine, but because it is less than 6 hours, we can convert partially with protamine sulfate, and we can give dose. There's no proper way to how to reverse fully and to come to a safe level of coagulation, but we can give tranexamic acid and reverse with partial reverse with protamine and go ahead with the section. But if possible, we can delay the surgery as much as possible close to the 12 hours. Then the risk of bleeding is very low. Better to avoid that epidural anesthesia or spinal, and we can discuss with the anesthetist and the VOG and try to come to a we can decide the time to deliver in a safe time.
Thank you, madam. So, fortunately, her last dose of enoxaparin was 14 hours prior. So she was she underwent an emergency cesarean section under spinal anesthesia, where she delivered a healthy baby with weighing 3.35 kilogram, and the prophylactic anticoagulation continued postpartum 6 weeks. That is a happy ending of this pregnancy. That brings me to the end of the presentation. Thank you. Thank you.
I am Dr. Sayantan, Registrar in Clinical Haematology, National Hospital, Sri Lanka. Since we are running out of time, I will briefly finish off the presentation. My topic is all about antiphospholipid and pregnancy. I'm going to present 3 brief cases to establish the better understanding of APLS in pregnancy. My first case is 25-year-old G1P0 with 1 prior DVT, which was 2 years back, that is iliofemoral DVT. Now she presented with a POA 5 weeks with a positive home pregnancy test. For the evaluation of DVT 2 years back, she was underwent lupus anticoagulant, which is positive, and anticardiolipin and beta-2 glycoprotein titers also positive. That was repeatedly confirmed after 12 weeks apart. She is currently on warfarin 7.5 milligram daily. Before going to the question and discussion, just going to brief about the antiphospholipid syndrome. To diagnose antiphospholipid syndrome, you have to demonstrate APLS. She had a DVT and now came with a pregnancy of POI 5 weeks. So my question to the ANOMA madam, how would you treat a pregnancy?
The patient is on warfarin 7.5 milligram daily because of the DVT and APLS. During pregnancy, anyway, the risk of thrombosis is very high, and dose of warfarin is more than 5 milligram. Therefore, we have to convert to enoxaparin and should be on therapeutic dose. Need to continue throughout the pregnancy as well as for 6 weeks postpartum and peripartum period. We have to adjust as we discussed before.
Yes. Thank you, madam. The second question goes to the Dr. Prabodhana sir. What are the anticipated risks should be counseled in this patient?
So the now because she's having APLS, so we have to talk about miscarriages, then the what we call second try miscarriages, preterm labors, preeclampsia, intrauterine death, fetal growth restriction. So actually, all of the placental diseases we call them are at a higher risk of this patient, apart from the DVT and all the other risks that patient may get. But obstetric wise, because the placenta, there can be problems with the placentation, which give rise to all the complications which are associated what we call placental diseases.
Thank you, sir. My second case, she's 32-year-old G2P naught, now POF 8 weeks. She had a first pregnancy end up with severe preeclampsia and fetal death at 22 weeks. The pre-evaluation, lupus was positive and anticardiolipin also positive. Before going to the discussion, I will just brief the obstetric criteria for APLS. As you remember, the clinical criteria, you should have one thrombotic event or pregnancy morbidity. In the pregnancy morbidity, there are three things. You should have 3 or more consecutive spontaneous miscarriages before 10 weeks of gestation, or 1 or more unexplained death of morphologically normal fetus at or beyond 10th week of gestation. Third one is 1 or more preterm birth of morphologically normal neonate before 34 weeks of gestation because of eclampsia or severe preeclampsia or features of placental insufficiency. So this case 2, she had a laboratory criteria with a preeclampsia and fetal loss. So we can diagnose as obstetric APLS. So to the madam, what is the important laboratory markers for adverse pregnancy outcome linked to the antiphospholipid syndrome?
Actually, that DRVVT is moderately positive. LA1 LA2 ratio is 1.9, and anticardiolipin, IgG, and DRVVT are both R is to fetus in APLS.
My second question is, what would be the appropriate treatment during her pregnancy?
Lupus anticoagulants, she should be on prophylactic dose of low molecular weight throughout the pregnancy and postpartum also to prevent thrombosis and to prevent fetal loss. So aspirin also should be given with prophylactic dose of insulin.
Thank you, ma'am. My third case, she's 34-year-old G4P naught. She had 3 first trimester miscarriage. First one at 5 weeks, then second one at 6 weeks, and third one at 8 weeks. All 3 miscarriages not evaluated. Now currently she's pregnant at POF 6 weeks. At that time she was evaluated. Lupus was negative, anticardiolipin and beta-2-glycoprotein titers are well lower than the optimal margins. So literally that APLS antibody screenings all are negative. So the question to the madam, what is the value of doing APS laboratory investigation while on pregnancy?
During pregnancy, that test may be falsely negative. Therefore, we should avoid testing during pregnancy as much as possible. And sometimes we may have to rarely do it less than 10 weeks of the period of gestation, but I would advise to avoid during pregnancy.
Thank you. So next question to the sir, what are the other causes for first trimester miscarriage in the absence of APS?
Okay, right. So there are
When you refer to me, what I do is, in this patient, 34 years, I take the history whether she has taken aspirin in the previous pregnancy. If not, I am very much sure she will do better in this pregnancy with aspirin, and she doesn't need enoxaparin. With my experience, more than 90% patients delivered without any problem, only with aspirin. But as you said, if the mother is old and any other issues with the mother, and we can consider enoxaparin.
Thank you. That's all. End of the coagulation symposium.
So that concludes the symposium, third symposium. May I kindly invite Professor Rasika Hera, Chairman, Scientific Activities and Research of Sri Lanka College of Obstetricians and Gynecologists, to deliver the vote.
Thank you very much. It's a great pleasure to having a occasion like this. In a era where hematological problems contribute or maybe that we are linked to hematological things to the top five causes of maternal death in Sri Lanka, including PPH, heart diseases, hypertensive related problems, and coagulation problems, thrombosis, pulmonary embolism, all of that. You name it, maternal mortality. Yes, we have our colleagues help us with that. So it's a great event. I think it went on very well, and I would like to appreciate the contribution made by all of you in this regard. From SLCOG's point of view, I would like to take this opportunity to thank College of Hematologists, led by Dr. Anoma and their team, and all the resource people from College of Hematology in providing information, participating, take their valuable time off and coming here to contribute this session. My cardiology colleagues, Sampath and their team, and we had two physicians, Dr. Botej was here, I think, and Dr. Palimulla madam was here, and thank you for all of them for their contribution. Then I would like to take this opportunity to thank Professor Anand Roll, the president of SLCOG, who was the strength of all of these academic activities conducted by SLCOG. I think we haven't seen a year like this for a long time. And thank you very much for all our trainees who participated, who contributed, presented your cases, and all the listeners who joined physically and from Zoom. There were a lot of participants from Zoom, I think. Thank you very much for joining us. So I would like to take this opportunity to present some certificates of appreciation for all the resource people. May I invite Professor Sanat Androl to participate and hand over some certificates.
Dr. Lochani Dasanayaka, Dr. Punsisi Nisanka, Dr. Jayanti Bhavantan, Dr. Sashi Prabha Senaviratna,